Días a todas y a todos. Me da mucho gusto presentar a ustedes, a quienes presiden esta ceremonia de inauguración de este Congreso Internacional de Atención Humana por los Pacientes. Con la representación del licenciado Eduardo Clark, subsecretario de Integración Sectorial y Coordinación de Servicios de Atención Médica, tengo el gusto de presentarles a la doctora Laura Cortés Sanabria, Directora General de Calidad y Educación en Salud de la Secretaría de Salud Federal. Bienvenida, Laura. Nos acompaña también la doctora Alba Alejandra Santos Carrillo, Directora de Prestaciones Médicas del Instituto Mexicano del Seguro Social, con la representación del maestro Zoé Robledo Aburto, Director General del Instituto. Bienvenida, doctora. Está también con nosotros la doctora Odette Sarabia González, Comisionada Nacional de Arbitraje Médico. La doctora Cristina González de Jesús, del Consejo de Salubridad General, responsable de la certificación. La doctora Yamila Gómez, asesora de Sistemas y Servicios de Salud de la OPS-OMS México, con la representación del doctor José Moya, representante de la organización en México. Bienvenida. El ingeniero Guillermo Funes, presidente de la Cámara Nacional de la Industria Farmacéutica. Y los presidentes de nuestras dos asociaciones de hospitales privados. El licenciado Álvaro López Aldana, presidente de la Asociación Nacional de Hospitales Privados, y el licenciado Francisco Valdés Real, presidente del Consejo de Administración del Consorcio Mexicano de Hospitales. Agradecemos su presencia, como la de todos ustedes. Cedo ahora la palabra a nuestro presidente, al doctor Carrillo Esper, quien preside esta ceremonia. Por favor, doctor Carrillo.
Muy buenos días a todas y a todos ustedes. Sean bienvenidos a la Academia Nacional de Medicina de México, tanto quienes se encuentran aquí en el recinto como a todas y a todos aquellos que nos siguen por las redes de la corporación. Paz y bien. El día de hoy es un día muy especial por el evento que se va a realizar y por las distinguidas personalidades que integran la mesa de honor. Sean todas y todos ustedes muy bienvenidos, dado que su presencia da certeza y gran proyección a este evento, como les digo, de gran relevancia, no nada más para la Academia Nacional de Medicina de México, sino también para la medicina nacional, la medicina de nuestro país, dado que se va a tocar un tema que retoma la esencia propia de la medicina. Desde que el ser humano empezó a ayudar a su semejante para ayudarle cuando tenía algún problema grave y tenía que ser rescatado, tratado médicamente de diferente manera, acorde a los tiempos y circunstancias que se vivían, nació esa relación estrecha entre los seres humanos, que ya no nada más era para la protección, la alimentación y el cuidado de su comunidad, sino también para tratar a los que más sufrían o los que padecían de algún tipo de enfermedad, acorde a lo que se vivía en su momento. Y así nació la medicina. Y la medicina nació con esa cercanía entre quien trata y quien sufre, y la comunidad que lo rodeaba, esas pequeñas comunidades tribales de esta unidad primigenia de la que nosotros todos venimos. Y esa esencia humana del trato en esta relación comunidad, médico y paciente se vino ampliando y fue creciendo acorde a la comunidad humana también iba desarrollándose e iba poblando el planeta. El trato humano, el trato de esta nueva esencia de la forma cognitiva en la cual la comunidad veía a sus semejantes, ha llegado hacia nosotros. Desgraciadamente, nos enfrentamos a un arma de doble filo, el desarrollo científico y tecnológico. En los últimos 100, 150 años, el desarrollo científico, tecnológico, organizacional, administrativo y normativo de la medicina ha sido impresionante. De esa medicina tradicional paternalista, de un núcleo pequeño, ha venido a ser ahora un tratamiento masivo de pacientes a nivel global. Tomemos en cuenta que somos ya casi 9,000 millones de seres humanos. Muchos de estos seres humanos en este momento, mientras estamos dando por inicio este gran congreso, esta gran jornada académica, están enfermos. Están enfermos en su domicilio, en su comunidad o en alguna institución de atención médica, en todo el planeta. Muchos están siendo operados, muchos están siendo atendidos en consulta, muchos están falleciendo en este momento, cuando la medicina fracasa en su resultado para prolongar un poco más la vida. Entonces, en este gran desarrollo humano, tecnológico, normativo, administrativo, científico, se fue diluyendo la esencia inicial de la medicina, que era esta relación estrecha con el paciente y su comunidad, como ya se los comenté. Y bueno, se sacrificó esto en aras de la ciencia y la tecnología. Pero la ciencia, la tecnología y el trato humano, lo que es la esencia de la medicina, no están peleados ni divididos, al contrario, tienen que sumar y fortalecerse. La ciencia y tecnología sin trato humano no deja de ser ciencia y tecnología. El trato humano sin ciencia y tecnología también queda desnudo, queda abandonado a como se hacía medicina hace varios cientos de años. Por eso el día de hoy es muy importante, porque se retoma lo que era y se le da la importancia de lo que tiene que ser. Y esto tiene que ir más allá del trato humano a nivel institucional, a nivel hospitalario, ya sea público o privado. Esto tiene que llegar a la comunidad y tiene que llegar al paciente, una vez que ya sale del ámbito médico, hospitalario, institucional o de la consulta. Y esto tiene que llevarse también en la enseñanza de la medicina. Si ustedes analizan las currículas de las diferentes escuelas de medicina, se trata de todo, con grandes avances, pero se ha dejado de tratar y de enseñar la esencia médica, la filosofía, la ética, la moral y el trato humano. Entonces esto tiene que enseñarse a nivel de la escuela de medicina, en la residencia, en las maestrías, en los doctorados, porque les digo, ciencia que no tiene una aplicación social humana, moral y ética, es una ciencia vacía, es una ciencia que no tiene mayor repercusión y que no va a dar los resultados debidos. Por eso este día, doctor Ruelas, distinguidos miembros de la mesa de honor, señoras y señores, es un día muy especial. Con esto arranca el año académico de la corporación. ¿Y qué mejor que con esto? Porque es el mensaje que quiere enviar la Academia Nacional de Medicina. Aplaudir la ciencia, la tecnología, pero sobre todo en el basamento de un trato humano, en todos los ámbitos. Así que bueno, sean todas y todos ustedes muy bienvenidos. Van a ser 2 días de intenso trabajo académico, de intenso trabajo también filosófico y ético, porque vamos a desentrañar esta esencia médica a través de las pláticas que se van a impartir y también se va a hacer constancia de cómo instituciones han hecho un gran esfuerzo, porque es un esfuerzo muy grande, tanto de los tomadores de decisiones como del personal que labora en estas mismas, en estas instituciones, para llevar a cabo esta práctica de trato humano de una manera procesual, o sea, a través de un proceso de atención. No nada más como yo pienso que tiene que ser, sino como me recomiendan que tiene que ser. Y eso en todos los ámbitos de la atención. Así que muchísimas gracias por su presencia. Gracias, doctor Ruelas, por el gran esfuerzo realizado para llevar a cabo este gran evento. Reiterar el agradecimiento tanto a las distinguidas personalidades de la mesa de honor como a todas y todos ustedes. Disfruten el evento y muchas gracias.
Muchas gracias, señor presidente, por su bienvenida. Hace 14 años, en esta misma tribuna, y con motivo del inicio del año académico de esta corporación, narré la experiencia vivida en un hospital de medicina tradicional china, cuando me hicieron pasar a un consultorio de consulta externa y parado detrás de la doctora que daba la consulta, me sorprendí viendo entrar a una mamá con su niña de unos 10 años al consultorio para consulta. En el consultorio no había sillas para los pacientes, solamente existía una silla para la doctora y un escritorio para ella. Y yo estaba parado detrás de ella con una traductora, que finalmente no fue necesaria durante todo el proceso de atención. Porque ese proceso de atención, en esa consulta externa, inició en silencio y continuó en silencio. Y la doctora veía a la niña fijamente, y la niña con su mamá tomadas de la mano, paradas frente al escritorio. Después de un buen rato, que genera una expectativa enorme porque no sabe uno qué hacer, la doctora escribió en su recetario, entregó con toda la caravana propia del Oriente la receta a la mamá, quien también respondió con una caravana. Salieron y no me dio palabra alguna. Cuando esto ocurrió, le pedí a la traductora que le preguntara a la doctora qué veía. Y la respuesta fue sorprendente. Lo he narrado muchas veces desde entonces hasta ahora, y hoy lo repito en este foro. La respuesta contundente, sencilla, directa fue: veía el alma de la niña. Nunca supe qué veía, nunca lo sabré, pero diagnosticó, prescribió y seguramente dejó un gran impacto, no solo en la niña y su mamá, sino en mí. Dejó una impronta que me hizo pensar después, ¿qué hacemos nosotros en Occidente para ver el alma de los pacientes? ¿Sabemos qué hacer deliberadamente para ser humanos con los pacientes? Y subrayo la palabra deliberadamente, porque nadie pone en duda que hay médicos, enfermeras, camilleros, recepcionistas, trabajadores sociales, que son muy humanos con los pacientes, pero también sabemos que hay otros que no lo son. La pregunta no es entonces si somos o no somos. La pregunta es si sabemos qué hacemos, porque aún quienes lo hacen, es muy probable que no sepan exactamente cómo lo hacen. Hace 25 años, exactamente un día como hoy, 22 de enero del año 2001, en el patio de la Secretaría de Salud Federal, en el edificio de Lieja, se daba inicio formalmente a la Cruzada Nacional por la calidad de los servicios de salud. Hoy hace exactamente 25 años. Una cruzada que se enfocó en dos grandes aspectos. Uno, la atención médica efectiva. Uno supondría que todos damos atención médica efectiva, así como todos suponemos que damos atención humana. Pero cuando vemos los errores médicos, cuando vemos los errores de prescripción, cuando vemos que los resultados clínicos no corresponden a lo que esperaríamos, nos damos cuenta de que sí era necesario hablar de atención médica efectiva y hacer cosas deliberadas para que eso ocurriera. Y la otra vertiente fue lo que se denominó en aquel momento trato digno, atención médica efectiva y trato digno. Y surgió una palabra, sonríe, que pude utilizar como acrónimo para comunicar lo que queríamos hacer con aquella cruzada. Si vemos la palabra sonríe escrita verticalmente, entonces, decíamos, es seguridad para los pacientes, oportunidad en la atención, necesidades satisfechas, resultados clínicos que puedan ser medidos con indicadores que nos revelen la efectividad de la atención. Pero por el otro lado, las tres últimas letras, respeto, información que entiende el paciente y empatía. Ese sonríe sigue vigente, pero debo reconocer que en aquella época trato digno no significaba lo que hoy significa y que el alcance fue muy limitado entonces. En 2014 me hice pues esta pregunta nuevamente, después de aquella experiencia en China. ¿Sabemos deliberadamente qué hacer? Y se empezaron a hacer una serie de encuestas. Hoy tenemos 16 encuestas acumuladas en los sectores público y privado, con una muestra representativa original que ahora se ha ido incrementando, de médicos, enfermeras y personal de apoyo, personal técnico, fundamentalmente. Más de 3.500 encuestas al día de hoy, que permitieron demostrar que en efecto no sabemos deliberadamente qué hacer para ser humanos. Deliberadamente. Y así en 2020, en el primer congreso de la Asociación Nacional de Hospitales Privados, en donde tuve el honor de participar, empecé a esbozar lo que podría ser una siguiente cruzada, una cruzada por la atención humana en salud, causa con una H intermedia. Y de pronto nos golpeó la pandemia. Y con la pandemia nos cimbramos cuando encontramos escenas que, creadas por el escenario de la pandemia, nos hacían ver muertes solitarias frente a caras protegidas, sufrimientos dejados a su suerte, grandes voluntades, actos heroicos del personal de salud, agotamientos desoladores, caras humanas frente a caras humanas mediadas por el dolor y la incertidumbre. La importancia de la atención humana se hizo evidente, más que nunca. Y en 2021, ahora, con el apoyo del Consorcio Mexicano de Hospitales, iniciamos un proyecto piloto con 6 hospitales para tratar de aterrizar lo que hoy es causa como una certificación de atención humana, pero sigue siendo una cruzada. Y es una cruzada por la atención humana, causa por una causa. Hoy convergen situaciones, voluntades, hechos que nos hacen pensar que 2026 amanece con el pie derecho. Se ha dado una afortunadísima coincidencia en el año 2025. Primero sí, hay una masa crítica ya de hospitales certificados en atención humana. Pero más allá de eso, debo reconocer y debo señalar la iniciativa de la doctora Patricia Clark, como secretaria del Consejo de Salubridad General, para reconfigurar la certificación de hospitales. Y bajo la experta conducción de la doctora Cristina González, aquí presente, en esa reconfiguración de los estándares del Consejo, aparecen estos criterios, estos estándares, que tienen que ver ahora con la distinción de buenas prácticas. Y una de esas buenas prácticas es la atención centrada en las personas. Esto no existía así en el Consejo. Pero este mismo 2025, bajo el liderazgo del subsecretario Clark, y con la enorme capacidad de liderazgo, de compromiso y de experiencia como investigadora de la doctora Laura Cortés Sanabria, se formula la Estrategia Nacional por la Calidad de los Servicios. Y también con un compromiso marcado en la atención humana. Concluyo el año con la iniciativa que se toma en el gobierno federal, en las instituciones de salud, del sector público, de impulsar el trato digno a los pacientes. Y aquí debo decir, esto no es nuevo. Había escuchado al maestro Zoé Robledo en varias ocasiones preocupado por el tema en los últimos años. Y había visto la acción de la licenciada Gabriela Paredes, responsable del área de atención a derechohabientes, esforzadamente atenta para atender estos temas de atención humana a sus derechohabientes. Ahora, con la doctora Santos, también desde la Dirección de Prestaciones Médicas, se cierra la pinza en el Instituto Mexicano del Seguro Social y se impulsa en un área que siempre ha estado, con la doctora Arbizu, de atención, de calidad de la atención médica en el instituto. Y se suma a esto la iniciativa del doctor Alejandro Esbarcho en IMSS Bienestar, también por impulsar el trato digno, y no podría dejar de mencionar al ISSSTE. Hace 25 años, nuestra preocupación central empezó a ser la seguridad de los pacientes. Y desde la cruzada empezamos a impulsar la seguridad de los pacientes por primera vez en México. Y el liderazgo lo tomó la doctora Odette Sarabia, también afortunadamente hoy aquí. Y como ven, confluyen los astros, se alinean los astros. Y decía yo, 2026 amanece en una situación que no teníamos hace un año apenas. Hoy este Congreso tiene una razón de ser. Hoy convergen los sectores público y privados con acciones concretas, con experiencias, para seguir impulsando en este país la atención humana. Y la Academia Nacional de Medicina, en sus 162 años de historia, que ha atestiguado la evolución de nuestra medicina y de nuestro sistema de salud, acoge estas iniciativas e impulsa con ellas y se suma con todos a este esfuerzo por ser cada vez más humanos con los pacientes. Esto explica un primer Congreso de Atención Humana en México que hoy se justifica plenamente. Hoy estamos aquí y convergemos todos, sectores público y privado, porque finalmente todos los mexicanos somos humanos, estemos atendidos en donde estemos atendidos. Permítanme hacer un par de reflexiones. Y cito dos disyuntivas que se nos presentan con frecuencia: definir o actuar. Empiezo diciendo que para muchos todavía la calidad es un concepto etéreo. Es algo que se logra con buena voluntad. Hoy ya sabemos que eso no es así, y lo sabemos en todo el mundo. Las cosas no mejoran con buena voluntad. Y sigue habiendo errores, y sigue habiendo personas dañadas, y sigue habiendo diagnósticos que no corresponden con el cuadro clínico, y sigue habiendo prescripciones que no corresponden con el diagnóstico que no corresponde con el cuadro clínico. Hay que saber de calidad, y hay que definir la calidad. Y por eso surgió la especialidad en calidad de la atención clínica. Hubo una razón de eso. Pero dentro de esta concepción, en estas definiciones, también tenemos que considerar que ha habido múltiples términos para hablar de lo mismo. Y ahora me refiero a la atención humana: calidez, trato digno, empatía, compasión, humanismo, humanización. ¿Por qué tenemos que utilizar tantos términos para un mismo concepto? Tal vez porque no están claros. En este mismo foro, hacia el final del año pasado, en presencia de nuestro presidente, hacía yo el ejercicio aquí de imaginar qué pasaría si yo a un gastroenterólogo le preguntara: dígame usted qué es gastritis. De inmediato respondería. O a una cardióloga: dígame usted qué es infarto agudo del miocardio. De inmediato respondería. Pero si yo pregunto: dígame usted qué es atención humana, les aseguro, van a empezar las dudas. Van a empezar las especulaciones. Bueno, yo creo que, me parece que, ¿por qué doctor, por qué doctora no me responde tan concisamente, tan precisamente qué es atención humana como lo hizo con gastritis o con infarto? Porque todavía vivimos en un mundo confuso cuando hablamos de atención humana. Y por eso la necesidad de definir. A Sócrates se le atribuye decir que el principio de la sabiduría es una definición. Empezamos por entender lo que era atención centrada en las personas. Un concepto que sin duda enmarca lo que estamos haciendo hoy aquí. Pero tuvimos que precisar todavía más dentro de la atención centrada en las personas qué es atención humana. Y así propusimos como definición, que se fue fortaleciendo a lo largo de los años, una relación profesional honesta, amable, confiable y respetuosa, que crea confianza mutua, que reconoce y acepta al otro como una persona plena con características individuales y lo protege de sufrir daños. Porque no se puede ser humano con alguien si no se le protege de sufrir daños, o peor aún, si se le causa algún daño como consecuencia de algún descuido. Eso es el marco de la atención humana como definición. Aquí cabe trato digno, aquí cabe calidez, aquí cabe humanismo, aquí cabe humanización, pero necesitamos un piso firme de definición para poder seguir avanzando. Pero no basta definir. Decía yo, hay una aparente disyuntiva, ¿definimos o actuamos? Pues aquí no hay disyuntiva real. Definimos y actuamos. Pero ¿cómo actuamos si no está definido en términos de acciones concretas lo que es ser humano? Y ahí surgió el concepto del código humano, como acciones concretas que permiten que se exprese la atención humana desde quienes dan el servicio hacia quienes lo reciben, que por cierto no son solamente los pacientes, sino también sus acompañantes. No basta entonces definir, es fundamental actuar. La disyuntiva es falsa. Pero déjenme agregar otra reflexión más. ¿Descubrir o humanizar? Se estila hablar de humanización, de humanizar. Y cuando hablamos de humanizar, yo siempre pregunto, ¿estamos hablando de seres humanos? ¿Tenemos que humanizar a los humanos para que sean humanos? ¿Tenemos que mojar el agua para que sea agua? Ya somos humanos. Entonces, tal vez no se trate de humanizar, se trata de descubrir, de ayudarnos todos a descubrir la capacidad que tenemos de ser humanos con los humanos. Y recuerdo aquí una escena de un niño preguntándole a uno de los grandes escultores contemporáneos, ¿cómo sabías que había un caballo adentro de la piedra? Somos humanos. Se trata entonces de descubrir el potencial que todos tenemos, más que de humanizar. Siempre he dicho y lo seguiré repitiendo, humanizar me suena a barnizar. Recordemos aquí a Octavio Paz. Soy otro cuando soy los actos míos. Son más míos si son también de todos. Para que pueda ser, he de ser otro, salir de mí, buscarme entre los otros. Los otros que no son si yo no existo. Los otros que me dan plena existencia. Ya somos humanos. ¿Y tiene valor ser humanos con los demás? Porque esta es la otra gran pregunta. Por supuesto que tiene valor, es un valor per se y es un valor ético. Pero ¿realmente tiene efectos? Déjenme darles algunos hechos. La atención humana tiene efectos fisiológicos, psicológicos, de adherencia terapéutica, de impacto en la seguridad de los pacientes, de impacto en el burnout del personal. Déjenme darles evidencias que ya conocen algunos de ustedes porque las repetimos con mucha frecuencia, pero no puedo dejar de citarlas hoy. Y son estudios en revistas indexadas. 20.961 pacientes diabéticos atendidos. Cuando son atendidos por médicos calificados como de alta calidad de atención humana, 41% menos probabilidades de complicaciones serias. No es solamente un asunto de metformina, no es solamente un asunto de recomendar nuevos estilos de vida o bajar de peso, es también de atención humana. Y en ese mismo estudio, 25% menos hospitalizaciones. Insuficiencia cardíaca crónica, disminución del 23% de síntomas depresivos. Dolor crónico, 36% menos estrés en los pacientes. Cirugía. ¿Qué pasa con los pacientes quirúrgicos? Cuando reciben atención humana, 4 veces más probabilidades de reportar buenos resultados, 6 semanas y 1 año después. Pacientes con cáncer, atención humana, disminución de cortisol, aumento de respuesta inmune y obviamente mejor pronóstico, hasta 1 año más de sobrevida. Solamente por ser humano. ¿Solamente? Quitemos solamente por ser humanos. Y ahora el desafío de nuestros tiempos, la inteligencia artificial. Con frecuencia pregunto, ¿ustedes creen que la inteligencia artificial nos va a superar algún día en el trato humano a los pacientes? Y la respuesta generalmente se inclina a decir, no nos puede superar, somos humanos. Cuando alguien dice, sí nos podrá superar, la pregunta es, ¿cuándo? Bueno, pues yo creo que algún día. ¿Cuándo? Hechos. 2023. Journal of the American Medical Association, artículo publicado, título: Chatbots superaron a los doctores en responder preguntas de los pacientes con precisión y empatía. 2022, Journal of Medical Internet Research, 85% de precisión de la inteligencia artificial en la interpretación de emociones. ¿Cuándo nos han enseñado a interpretar emociones? Ya les enseñó alguien a la inteligencia artificial a hacerlo. Y lo está haciendo bastante bien. Nuevamente, en este artículo de JAMA, que cité al principio, 78% de los pacientes calificaron las respuestas de la inteligencia artificial generativa como más amable y empática que los médicos. Estamos entrando, pues, en una nueva frontera. La atención humana no puede seguir siendo para los médicos, enfermeras y todo el personal de los hospitales, todos, un punto ciego. Tiene efectos, y tiene efectos positivos, pero tenemos que saber qué hacer. Así pues, el objetivo de este Congreso es fortalecer la atención humana a los pacientes y sus acompañantes en los sectores público y privado del Sistema Nacional de Salud de México. Sé que nos ven de otros países, y lo sé porque nos han llegado las solicitudes para poder conectarse el día de hoy. Y sé que tenemos a un grupo importante desde Chile y desde Argentina, y les agradecemos su presencia. Y aunque nos estamos enfocando en el Sistema Nacional de Salud de México, esperamos que esto también pueda contribuir a seguir fortaleciendo la atención humana en todos nuestros países. Y cuando hablo de acompañantes, quiero subrayarlo por una escena que tal vez algunos de ustedes vieron esta mañana o han visto muchas veces, pero que es impactante, es desolador, es conmovedor ver tiendas de campaña con este frío afuera de los hospitales esperando a sus pacientes, esperando información de sus niños o de sus padres, de sus seres queridos, porque no hay dónde alojarlos. 7 grados sobre cero esta mañana en la Ciudad de México. Mientras no estén en el radar estos temas de atención humana, los presupuestos no van a ir para eso. El programa está constituido con la participación de grandes expertos extranjeros que tendremos hoy, de Estados Unidos, de Chile y de Argentina mañana. Grandes personalidades, el doctor Len Berry, cuya experiencia inicial fue como profesor de marketing en la Universidad de Texas A&M, pero muy pronto descubrió y se hizo famoso escribiendo un libro sobre la experiencia de la Clínica Mayo en Atención Humana. Y luego tenemos a Paul Barish, un experto en seguridad de los pacientes, pero un experto en seguridad de los pacientes que sabe que siendo más humanos podemos asegurar más la seguridad de los pacientes. Y luego Helen Haskell, a quien tendremos esta mañana también, la madre de un joven que falleció como consecuencia de un error médico y que tomó la iniciativa de crear, primero, la organización Madres contra los errores médicos y después Pacientes por la seguridad de los pacientes. Y después ser la consejera de la Organización Mundial de la Salud en el tema. Helen, una mujer ejemplar. Y cerraremos con Maureen Bisoñano el día de hoy, una enfermera internacionalmente reconocida, entre otras cosas, porque fue la presidenta del Instituto de Mejora de Calidad de los Estados Unidos, hoy es presidenta emérita y además una digna participante en la red de atención humana a los pacientes en todo el mundo. El día de mañana tendremos una exposición también a grandes expertos en nuestro país, a quienes hoy están haciendo posible que pongamos el tema en un congreso como este. Y empezamos con la doctora Laura Cortés Sanabria para que nos hable de la Estrategia Nacional de Calidad y su preocupación por la atención humana, y seguida por la doctora Cristina González, que, como decía yo hace rato, puso en los estándares, con el liderazgo de la doctora Clark, esta distinción de buenas prácticas por atención centrada en las personas, y la tendremos también mañana aquí. Y la licenciada Gabriela Paredes del Instituto Mexicano del Seguro Social, y el doctor Ábalos de IMSS Bienestar, para hablarnos de justamente esta iniciativa de trato digno. Y finalmente tendremos la experiencia de causa, con hospitales representados aquí, el Hospital Galenia, el Mater, el Grupo San Angelín y tantos otros que se han ido sumando. Desde luego no quiero dejar de mencionar la participación de Helen Haskell, de Evangelina Vázquez, que hizo lo mismo en México, creando Pacientes por la seguridad de los pacientes, otra madre afectada. Y finalmente tendremos desde Argentina a Gabriela Covelli, una abogada que perdió a su hijo también como consecuencia de un error médico y que después de años de lucha logró que el año pasado el Congreso argentino aprobara lo que es hoy la Ley Nicolás, el nombre de su hijo, para proteger a las personas que sufren daños como consecuencia de errores médicos. Concluyo. El futuro se inventa cada día y así se construye. Pero cuando se ha creído que está construido, es menester reinventar, volver a ser diferentes para no volver a ser. Tenemos que ser cada vez más humanos. Aprendamos a ver el alma de todos, cómo lo necesitamos en estos tiempos. El 30 de abril de 2014, el mismo día que se cumplieron 150 años de fundación de esta academia, dije como presidente en esta misma tribuna lo que ahora repito, en este marco de lujo, no por el escenario físico, sino por la presencia de todos ustedes. Atrevámonos a sentir más con el cerebro y a pensar más con el corazón para que así nuestros sentimientos sean más racionales y nuestros pensamientos aún más humanos. Mi agradecimiento, doctora Cortés, por su presencia. Mi agradecimiento a todos los miembros de este presidium que nos acompañan. Muchas gracias a todos ustedes aquí en el auditorio. Gracias a todos los que nos ven a distancia. Gracias. Como dije hace unos momentos, en 2024 inició formalmente esta certificación, que ya tiene un año. Casi 30 hospitales se han sumado, uno de ellos público, el Hospital Metropolitano de Nuevo León, en Monterrey. Han sido capacitados en atención humana, en código humano, más de 250 altos directivos, 529 líderes de atención humana y alrededor de 7,800 colaboradores de estos hospitales en código humano. Quiero agradecer al presidente, al doctor Carrillo Esper, su anuencia para entregar los más recientes certificados de causa en esta ceremonia. Entregaremos, pues, los certificados a estos hospitales, el certificado al primer hospital recertificado y un reconocimiento a los 5 primeros hospitales que se sumaron a esta iniciativa como hospitales pioneros. Y le voy a pedir a nuestro presidente que nos haga el favor de entregar estos certificados y estos reconocimientos. Empezamos con el Centro Médico del Noroeste. Clínica Quirúrgica de la Concepción en Saltillo. Hospitaria, Nuevo León, Monterrey. Hospital San Angelín, Chapultepec. Hospital San Angelín, HMG. Hospital San Angelín Patriotismo. Hospital San Angelín Sur. Hospital San José Satélite. Hermana, muy bien. Hospital San Angelín del Valle. Clínica Dental San Angelín HMG. Clínica Dental San Angelín del Valle. Y tenemos un primer hospital recertificado, que fue el primer hospital certificado, Hospital Galenia de Cancún, Quintana Roo. Y ahora reconocemos a los hospitales pioneros. Nuevamente el Hospital Galenia de Quintana Roo, que fue el primer hospital. Hospital Almater, Mexicali, Baja California. Hospital San José, Navojoa. Y Hospital San Diego, Cuernavaca. Con esto damos por concluida esta entrega de certificados y reconocimientos. Señor presidente, muchas gracias. Y iniciamos ya el final de esta ceremonia. Quiero solicitarle a la doctora Alba Alejandra Santos Carrillo que nos dirija un mensaje a nombre del señor director general del Instituto Mexicano del Seguro Social.
Muchísimas gracias, doctor Ruelas. Es un honor para nosotros contar con su presencia el día de hoy. Doctor Carrillo, muchísimas gracias. Doctora Oded, doctora, muchísimas gracias a todos los integrantes del Presidium. La verdad, reciban un saludo cordial de mi director, el maestro Zoe Robledo, comprometido completamente con este tema de trato digno y de calidad y seguridad en el paciente, que si hay una institución en este país que ha estado a la vanguardia y siempre comprometida con la calidad, es sin duda el instituto. Una vez que saludo a todos y como voy a hacer referencia a lo que mencionó el doctor Ruelas. Nunca como hoy, doctor, contamos con ese clima político que nos permite, ¿no?, pensar que este sí va a ser un inicio adecuado para el tema tan perseguido de calidad y seguridad en la atención médica. Desde la más alta tribuna de este país, la mismísima presidenta Claudia Sheinbaum, pues ha firmado dentro de sus 100 compromisos un gobierno sustentado justamente en el humanismo mexicano. Nuestro Plan Nacional de Desarrollo pues establece el eje general 2, el desarrollo con bienestar y humanismo, y la salud como un derecho humano, en busca de promover una república sana que adopte el humanismo justamente como una brújula, poniendo al centro a las personas, a los pacientes en particular, pero como bien lo mencionó, no solamente a los pacientes. Los procesos relacionados con la vida, con la salud, la muerte, más allá de su dimensión fisiológica, como bien mencionó el doctor Carrillo, y epidemiológica, pues son procesos que se viven de los dos lados, se viven desde la realidad de los pacientes y también se viven desde la realidad del personal médico y todo lo que acompaña al acto de la enfermedad, la salud, la incertidumbre en nuestro gran escenario que son las unidades de atención médicas o diagnósticas. Son procesos que son atendidos por personas situados en contextos históricos y sociales, culturales, diversos, por lo que los cuidados y atención a la salud deben de partir de una visión humanista, sin duda. El IMSS, los temas de hoy en la academia nos convocan a reflexionar que forman parte de un compromiso constitucional, un compromiso del instituto con los tratados internacionales de promover, respetar, proteger, garantizar los derechos humanos bajo los principios de universalidad. El humanismo y la justicia social pues se encuentran en el centro de nuestro quehacer. La salud y la seguridad social, que es nuestra causa, nos resulta de lo más alta relevancia que una de las políticas sea justamente fortalecer esta atención. Usted hizo mención en su participación haciendo remembranza de cuántas veces ha estado parado aquí, hablándonos de transformarnos e invitándonos al cambio y a que ahora sí va a suceder. Hemos asumido ese compromiso de establecer estrategias para la atención centrada en las personas, con reconocimiento, defensa y promoción de su dignidad, autonomía, equidad e inclusión. Dichas estrategias están dirigidas a impactar no solo los procesos de atención, sino la formación y la educación permanente del equipo multidisciplinario que brinda la atención a la salud. El uso de la traslación de los conocimientos que nos promuevan que las personas pasen menos tiempo en las unidades médicas, favoreciendo las atenciones ambulatorias, favorecer el acompañamiento de las personas, por las personas que ellas designen y no solamente por el esposo o por la mamá o por señalar desde la autoridad médica quién es el indicado para acompañar a las personas, la gestión de los casos complejos y el fortalecimiento de redes de atención a grupos vulnerables. El instituto sin duda es un aliado, doctores, para esta transformación a la que nos invitan. Vamos a seguir trabajando, lo hemos estado haciendo de la mano pues, del secretario de Salud a través de la academia, con la maestra Cristina, con todos ustedes. Pero también el IMSS ha hecho invitaciones que hoy voy a solicitar nuevamente, y creo que es muy importante empezar a hacer las cosas diferentes. La pregunta es, ¿cuándo aprendemos a maltratar a la gente? En todo nuestro plan académico, ¿cuándo aprendemos los médicos a maltratar? Han corrido ríos de tinta sobre este tema, ¿no? Muchos dicen que es cuando empezamos los ciclos clínicos, cuando el estudiante llega a los hospitales. Por eso es la invitación, y bueno, lo hemos dicho el IMSS en otros foros, es importante replantearnos la educación en general y la formación médica en particular, médica y de los servicios de salud. Respondemos a planes anacrónicos. El mundo está cambiando y nosotros no vamos al ritmo de lo que necesitamos cambiar. Nuestros planes formativos de pregrado y de posgrado son muy lejanos. ¿Qué es lo que buscamos que el estudiante o el médico futuro sepa? Esta violencia estructural de generaciones y generaciones que nos hemos formado bajo ese mismo ciclo, llena de mampostería nuestras unidades médicas y ha hecho una estructura rígida que ahora que queremos cambiar no nos permite movernos. Esto es algo que lo hemos presentado en otros foros. La violencia estructural sin duda se transmite hacia todos lados, hacia los pacientes, hacia los familiares y hacia los mismos trabajadores. Eso nos ha afectado, venimos también de una pandemia, y nos hemos acostumbrado a pensar que la calidad es que se diagnostique y se trate bien. No importa el camino que tomemos, no importa lo que quiere el paciente, no importa lo que quiere el familiar, no importa lo que cueste. Lo importante es que el gran maestro diga desde esa tribuna, otra vez formados en esas estructuras que traemos de mucho tiempo, pero creo que es el momento de replantearnos si realmente queremos impactar en las generaciones que vienen. Ahora con los compromisos y con los temas que trae nuestra presidenta, a lo cual el instituto y mi director general nos sumamos, como son la partería no pensándola desde que las parteras atienden en un rancho lejano, rodeado de pobreza, no. La partería pensándola como el acompañamiento de las mujeres a través del embarazo, parto y puerperio, ¿no? Para que regresen a su casa y se pueda sostener la lactancia más allá del egreso hospitalario. El acompañamiento en los padecimientos oncológicos, en que les podamos decir a esas mujeres que no diagnosticamos a tiempo, porque nosotros mismos ponemos esas reglas del diagnóstico, del tamizaje, y el 80% las diagnosticamos con enfermedades avanzadas. Decirles como sector que las vamos a acompañar, que no es necesario que van a morir y que vamos a ser amigables para que vengan, se traten, ¿no?, y se atiendan. Entonces, los albergues que usted mencionó es un tema que debo decirle le preocupa mucho a nuestra señora presidenta, a nosotros también. Nosotros teníamos los albergues en lo anteriormente denominado Coplamar, otra vez ligado a lo rural, a ese pueblo chino que usted mencionó, ¿no? Cuando las comunidades son un poco más amigables con las personas, ¿no? Cuando llegan a la ciudad, lejos, están fuera, no solamente de los hospitales de aquí atrás, en cardio. Entonces, esa experiencia que nosotros tenemos de hacer albergues es un compromiso institucional, ahora ya desde el hospital rural que tenemos hasta centro médico siglo XXI. El tratar, el acompañamiento, el favorecer que no estén tanto tiempo aquí, ¿no?, con industrias, bueno, como plataformas como telemedicina, no que venga el paciente de lejos para ver un estudio que se puede ver en redes, etcétera. No voy a abundar en este tema, pero creo que sí tomamos esas reflexiones, doctores, pero realmente para transformarnos de fondo. Trabajemos todos, pues, todos juntos, con seriedad y realmente con cambios que modifiquen esa estructura que tenemos para poder sacar a ese caballo que quedó atrapado en una piedra pesada. Muchas gracias, que sea para bien. Muchas gracias.
Gracias, doctora Alba Santos Carrillo, por este excelente mensaje que refleja la esencia de este Congreso, el trato humano, y bueno, también reiterar el reconocimiento de cómo el Instituto Mexicano del Seguro Social está retomando este principio tan importante en nuestro ejercicio cotidiano, iniciando, como bien dijo, desde la preparación de las nuevas generaciones de médicos. Gracias, doctor. Y bueno, ya para cerrar el evento inaugural, quiero pedirle a la doctora Laura Cortés Sanabria, directora general de Calidad y Educación en Salud, nos dirija un mensaje y haga la declaratoria inaugural oficial. Gracias, doctora.
Muy buenos días a todos. Doctor Raúl Carrillo Esper, doctor Enrique Ruelas, distinguidos miembros del presidio que nos acompañan. Bueno, pues muchas gracias. Y a nombre del licenciado Eduardo Clar, subsecretario de Salud, les manda un cordial saludo. Y bueno, sin duda alguna, quiero también sumarme a esas palabras de bienvenida del doctor Carrillo Esper, del doctor Enrique Ruelas, a este Congreso con razón de ser. Y que sin duda alguna será un espacio de reflexión, de diálogo y construcción colectiva que hoy convoca no solamente a los saberes científicos, sino también a saberes humanísticos en torno a un eje fundamental que es muy, muy necesario retomar, que es la atención humana a los pacientes. Y sin duda alguna también me congratulo cómo la Academia Nacional de Medicina, fiel a su vocación histórica, no solamente de liderazgo intelectual, sino también de compromiso social, se suma a esta Congreso, iniciativa que, como siempre, el doctor Enrique Ruelas nos lleva por delante. Y en ese sentido, quiero comentarles, como todos sabemos, que pues vivimos una época de avances científicos sin precedentes. Ya se comentó por quienes me precedieron en el uso de la voz. Con tecnologías cada vez más sofisticadas e innovaciones diagnósticas, terapéuticas, precisión, que sin duda alguna han transformado la práctica como la práctica médica. Sin embargo, pues eso también implica que tengamos un reto muy importante. Y no solamente un reto, varios retos. El primer reto es cómo asegurarnos que la ciencia y la tecnología estén siempre al servicio de la dignidad humana. Y en ese sentido, el reto es que hablar de atención humana a los pacientes no se transforme o no se conceptualice como una consigna retórica ni una moda conceptual, porque ese puede ser el riesgo, sino que realmente nos empoderemos y sea un principio ético, una responsabilidad profesional y una obligación social. El siguiente reto ya lo comentaba la doctora Alba: cómo hacer que las nuevas generaciones de profesionales de la salud reconozcan en cada paciente que cada paciente es más que un diagnóstico, más que un expediente clínico o un conjunto de indicadores biomédicos. Como decía el doctor Ruelas, es una persona con historia, con valores, con emociones, con miedos y esperanzas. Pero lo más importante, es una persona que confía en nosotros en un momento muy especial de vulnerabilidad en su vida. En ese sentido, creo que también dentro de este proceso de atención humana, no debemos de olvidar que también implica a los profesionales de la salud. También implica cuidar a quienes cuidan, cuya formación, cuyas condiciones laborales y bienestar emocional son determinantes para poder ofrecer y transmitir una atención verdaderamente humana. Estoy hablando del ecosistema de la salud. Y bueno, me congratulo también porque este congreso adquiere una dimensión no solamente nacional, sino internacional. Y también, reitero, me sumo a las palabras de bienvenida de aquellos países que nos están acompañando en este evento académico tan importante. ¿Y esto por qué trasciende esta vinculación internacional? Porque definitivamente los desafíos que enfrentamos para recuperar esa atención humana de la salud son los mismos. La deshumanización asociada a la sobrecarga de los sistemas de salud, las brechas de acceso y calidad, las tensiones entre eficiencia, productividad y cuidado compasivo, y la necesidad de formar recursos humanos con sólidas competencias técnicas, pero también con una profunda sensibilidad ética y social. Por favor, no dejemos de pensar con el corazón y sigamos sumando esfuerzos y voluntades para alinear los astros en busca de recuperar la atención humana de la salud. Muchas gracias. Y ahora me voy a permitir pedirles ponernos de pie. A nombre del subsecretario Eduardo Clar, siendo las 10:21 horas del día 22 de enero, declaro formalmente inaugurado el Congreso Internacional Atención Humana a los Pacientes, deseando que las jornadas sean profundamente enriquecedoras y fructíferas. Muchas gracias.
Muchísimas gracias, doctora, por sus palabras. Y damos por concluida esta ceremonia inaugural. Les pido que no se levanten de sus asientos. Inmediatamente después seguimos con el doctor Len Berry. Mientras tanto, nuestro presidente acompañará a nuestros invitados especiales para que puedan dejar este auditorio. Desde luego están cordialmente invitados a quedarse si pudieran hacerlo. Muchas gracias a todos. Sigamos aquí en nuestros lugares.
Sí, ya lo he escuchado en el
Esperemos allá para claro que sí. Gracias, qué amable. Saludos al señor representante.
My topic today. All right. Let me begin again. I was getting feedback. My topic is kindness, influence, trust, and healing in healthcare. Care human. I'd like to begin with Alice's story. Alice had a biopsy on a mass in her stomach. Her gastroenterologist was in his car driving home in heavy traffic. At the traffic light, the doctor saw the pathology results pop up in the electronic health record, and it was good news. The mass was benign. It was a Friday afternoon before a long holiday weekend. But despite the fatigue from his work week, Alice's physician drove back to the hospital in order to call her on the phone with the good news, instantly relieving her of her intense anxiety and bringing her to tears of gratitude. Alice's doctor could have waited until he was back at work on Tuesday after the long weekend, but he did not wait. He drove back to the hospital and he called Alice. And in doing so, he demonstrated the power of kindness, my topic for today. Healthcare is a high emotion service, especially for seriously ill patients. And what I mean by a high emotion service is a service we use as people that causes us great anxiety or uncertainty or even fear. And in the case of healthcare, we often experience that anxiety or fear even before we have the medical appointment, even before we have the medical procedure. Healthcare is as high an emotion service as an emotionally intensive service of any of the services available to consumers. I want to share with you today my unfancy model. I'm a professor, and professors are famous for their very fancy models. This is an unfancy model, but I hope you will find it powerful for you, useful for you. The model is kindness to patients influence patients' trust. And patients' trust in turn influences the healing of patients and the healing of those who care for them. And we'll go through this model step by step. First, kindness. Purposeful, voluntary action, undertaken with sensitivity to the needs or desires of another person, and actively directed towards fostering their being, their well-being, or their flourishing. Kindness comes not from a job description. It comes from one person's values, their personal values. It comes from our heart, our kindness. Care human, the theme for this conference, this beautiful theme. Care human starts with kindness, and it also ends with kindness. Kindness, based on the research I've been doing with clinicians and patients for more than 20 years now, kindness is presented in 6 different dimensions. 6 different lenses that we can think of for kindness. And I'll take you through each of them in a moment. But for the group as a whole, deep listening, empathy, generous acts, timely care, gentle honesty, and support for family caregivers. These are the dimensions of kindness in healthcare based on the research that I've been doing for many years across the United States and in some cases in Europe and in your country as well. First, deep listening. Actively listening to your patients. It conveys respect for their self-knowledge. Patients know a lot about themselves, and that's important in diagnosis and treatment. Active listening builds trust and it improves the decisions for treatment. Deep listening helps clinicians not only learn what is the matter with the patient, it also helps the clinician learn what matters to the patient. Think of this for a minute before I move on to the next slide. When we listen deeply, we convey respect, we build trust, we improve the decision-making. Because when we listen deeply, we not only learn what is the matter, what is wrong with the patient medically, we also learn what matters to the patient, what is most important to the patient. We learn about the patient's priorities and the patient's values. We learn more about the human being that we're caring for. We learn more to provide care human. Empathy, the second dimension of kindness, has 4 component parts. First, seeing from the other person's perspective. Second, avoiding judgment when we assess the situation. It's so easy for us in medical care, whether we're clinicians, nurses, doctors, or administrators, or working on the front desk or on the telephone. It's so easy for us to make an initial assessment because of the way the patient presents herself. Maybe the patient has tattoos, and maybe we don't like people with tattoos. But empathy is about avoiding that premature judgment and assessing the situation as objectively as possible. That's empathy. It's also recognizing the emotion present, recognizing it, and then responding to the emotion in particular and the patient in general in a caring way. Empathy. I've done a lot of my research in oncology, in cancer. And one of the questions in my interviews with cancer clinicians, doctors and nurses, that I always ask is there a certain phrase that you'll never use with a patient or a family member? Is there something that you'll never say to a patient? And everybody that I asked that question, several hundred people I've interviewed in the cancer community, had an answer to the question. Everyone had an example of what I call a never word or a never phrase. And you see some examples on the screen. There's nothing more that we can do for you. We should never say that to a patient. There's always more that we can do. We may not be able to cure. We may need to stop curative treatment, but there's always more we can do if we stand by the patient in helping the patient navigate to the next stage. When we say there's nothing more we can do for you, it implies that we're abandoning the patient. We're saying goodbye to the patient. We're saying it's over. The medical treatment, the medical participation and partnership that we have, we need to stop. We don't ever want to say that to a patient. Why did you wait so long to come in? It feels guilty when we say that to patients. It makes patients sensitive that they did something wrong. You failed chemo. That's a never phrase. It suggests the patient is at fault because the chemo didn't work. But in fact, the fact is the chemo failed the patient. The patient didn't fail the chemo. You were lucky it's only stage 2. We should never use the word lucky when we're talking to a patient diagnosed with cancer. There's nothing lucky about cancer. It trivializes a serious condition. Let's not worry about that now. In my study in oncology, I've been in the examination room with the patient and the doctor, watching, observing the interaction many, many times. And this is a common phrase that clinicians will use with patients when patients want to know their prognosis. They want to know how much time, they want to know how sick they are, they want to know the truth. Does every patient want to know the truth? Probably not. Do most patients want to know the truth? The answer is yes. There's a lot of empirical research to support that. And when we say, let's not worry about that now, when the patient is asking us, what is my prognosis, doctor? We simply make the patient more anxious than they were even before they asked the question. Never phrases are not empathetic. And I encourage all of you listening to my presentation today, attending the conference, to go back to your work unit with your colleagues and have a meeting where you identify as a group, what are the words we use, what are the phrases we use we should never ever use again with a patient or with family or with each other. And then as a group, commit to abandoning the use of those phrases. Commit to that. Never phrases. Another dimension of kindness is generosity, generous acts. Generosity is extra effort. It's going beyond what is essential. It's doing more. It's doing more. It's sharing of your resources, which can be your time, it can be your empathy, it can be your effort. It's sharing of your resources to fill a need in a way that uplifts both the giver and you as the giver and the recipient. So I want to, on this slide, I want to explain the concept of volunteerism. When we think of volunteers in healthcare, we think of the people who help out with at the hospital but don't get paid. They're volunteers. But in truth, we're all volunteers, all of us, including those of us who get paid for our work. And what I mean is, with volunteerism, I mean discretionary effort. Every one of us, every day in our work, make decisions continually about how much discretionary effort we are going to provide to the other person asking for our help. It could be our colleague, our co-worker, or it could be our patient, or it could be a family member. Volunteerism, discretionary effort, is the difference. It's a difference between the amount of effort and care you put into your work and the minimum amount of effort and care you put into your work. So the difference between the actual amount of effort and energy you put into your job in serving another person and the minimum amount required to avoid any kind of penalty on your job, it's discretionary, it's voluntary, it's extra effort, and it's kind. Extra effort on behalf of serving the person who's in front of you, who's asking for your help, who's depending upon you. Extra effort is kind. generous acts. I want to tell you the story of Susan. Susan was my student 7 or 8 years ago in my course at the university. She was my student, and she's now in her 20s and she's now healthy. But when she was 14 years old, she was diagnosed with brain cancer and then was scheduled for brain surgery. And when she wrote a term paper for my course, she wrote this story, and I'm going to read you this one paragraph from her story. She said, when Ava, my nurse, came by before surgery, she looked me in the eyes and she said, Susan, I'm going to braid your hair back so we only have to shave what we need. What Ava did shaped how I viewed myself every time I glanced in the mirror during my recovery, and whenever I walked into my school surrounded by normal girls. Ava probably doesn't remember braiding my hair, but that moment has stuck with me for the past 6 years. Ava surely had other tasks to do. She surely was busy, but she took the time to braid my hair anyway, an act of discretionary effort. Performing these actions, these kind actions, these extra efforts with intention is a way to reconnect with our purpose in healthcare and to mitigate against the moral distress associated with this work. The next dimension of kindness is timeliness, timely care. Timely care is particularly important in high emotion services like healthcare, because heightened emotions are likely to intensify the need for timeliness. Timeliness is often controllable. Even in healthcare, there's so much waiting in healthcare, but often we can reduce the waiting if we make our service system more efficient, and also if we take an empathetic and discretionary effort approach to our work. Timeliness is often controllable. Waiting, we've all been patients. Every one of us has needed health care in our lives and in our families' lives. And waiting for a long time for a medical appointment we need, waiting for a long time for a diagnosis that we are so anxious to receive, waiting for a long time for a treatment that we need because we're in pain and because we're in despair and because we're scared. Waiting in healthcare can be suffering, another form of suffering. So timely care is kind care. And then there is a fifth dimension, and that's gentle honesty. Asking patients how much they want to know about their condition, their illness, is informative and it's kind. Most patients want to hear the truth, but they need to hear the truth in the right way. They need to hear the truth in honest and well-chosen words, words that convey a sense of partnership and that help patients make the decision that is right for them. Gentle honesty is kind. For example, from one of my many interviews I've done in my oncology research, a nurse told me this: a doctor can say, we can continue treatment, or we can just do supportive care. we have to take the word just out of the sentence. Wow, think about this for a minute. When a doctor says we can continue treatment or we can just take supportive care, we can just take supportive care out, then you're putting your thumb on the scale and signaling to the patient that you, as the doctor or the nurse, as the clinician, you favor continuing treatment. But what about when we continue treatment that has no real possibility of cure or remission and is simply going to make the patient sicker as well as cost more money? Is that kind? It is not. And so that's why this nurse that I interviewed said, we have to take the word just out of the sentence. In this context, the word just is a never word. It's a never word. Gentle honesty. And finally, the sixth, last but not least, dimension of kindness is support for patients' families. It must extend in healthcare beyond the patient to the family, especially when there is serious disease or illness or injury. Supporting family caregivers in a role that they are often ill-prepared to perform, both cognitively and emotionally, bridges kindness and practicality. We have to do more for the family than we often do. So here, in the unfancy model, here we're ready to talk about trust. So kindness in all of its 6 dimensions influences patients' trust. And patients' trust in turn influences the healing, both of the patients and the people who care for them. Let's talk about trust. Trust is the willingness to rely on an exchange partner with whom one has confidence. It's a willingness to rely on the other party because you have confidence in them. There's no service that depends more on trust than healthcare, given how uniquely important and variable and complex and personal the healthcare service is to patients. There's no service, of all the services we use as consumers, there's no service that relies more on trust, that depends more on trust, that requires more trust than the service that you perform, all of you at this conference today. It's the bedrock of how clinicians establish genuine relationships with their patients. So, kindness to patients influences patients' trust. Patients' trust influences their healing and the healing of those who care for them. So let's talk about healing now. The primary missions of healthcare are to offer, first, health, which is the prevention of disease, and healing, which I define as physical and mental healing when it's possible, but also emotional healing as needed. Health and healing are about more than medication. It's about more than technology. It's about more than procedures. Health and healing concern furthering a person's well-being. This is one of my most important slides. I hope they're all useful to you. Obviously, I want every slide to be important, but this slide is one of the most important. We can heal even when we cannot cure. That's the way we need to think about healing. We can heal even when we cannot cure. There's 3 types of hope. The first kind of hope is focused hope, and focused hope is centered on the future. The patient and the family are focused on the future, and they hope for cure, they hope for remission, they hope the treatment will work. But what about if cure is not available? What about if cure is not possible? Does the patient need to lose hope? And the answer is no. There are other forms of hope that clinicians can help guide patients to when cure or remission, effective treatment is no longer possible. The second kind of hope is intrinsic hope. And intrinsic hope is hope that's centered on the present day, on today, where a clinician guides and helps a patient navigate to hope for a good day today, a day where the pain is less or the pain is absent, a day when the sun is shining and you can be outside and enjoy nature, a day when your grandchildren are going to visit your home and be with you, a day when you're going to be with your spouse, doing something fun. But yeah, that's intrinsic hope, where you're focused on the present, on living as well as you can every single day that you have left in your life. And then there's even a third kind of hope. And this kind of hope, this level of hope we call freedom hope, was taught to me and another physician, a hospice physician that I work with. It was taught to us by a parent whose child was dying and did die from brain cancer at the age of 6. And she taught us a third kind of hope, freedom hope. And she taught us that there comes a time when it's time to, whether for yourself or for your child or for your loved one, it's time to allow them to fly with the angels, to give them the freedom to let go of all the treatments, of all the medication, of all the side effects, of all the fear, to give them the freedom to let go. If we can think of all 3 kinds of hope instead of just the focused hope for a cure, then we are in position, especially those of us in clinical work, we are then well positioned to feel confident in telling patients gently but honestly the truth about their condition and the prognosis without them losing hope, helping them navigate to a different kind of hope. So this is why I say this slide is particularly important. So here is my proposition. Just have a few more slides to go before I finish. This too is a very important slide because everything that I've talked about today leads up to this slide, this proposition. Kindness influenced trust, combined with competence influenced trust, has stronger effects on healing than competence influenced trust alone. Now, think of it this way. Those of you that are clinicians, those of you in the audience today listening to me present, who are nurses or doctors or other clinicians who actually provide treatment. When patients come to see you for the first time, they are assuming that you are competent. They are assuming, if you're a nurse, that you know what nurses are supposed to know. If you are a doctor or surgeon, you know what a doctor needs to know. If you're a surgeon, you know how to do the surgery that you're going to do. They are assuming you're competent unless their experience with you as time goes on shows them that you're not. So you start with competence, influence, trust at that first meeting with most of your patients, maybe not all of them, but most of them. They assume you're competent because you're a doctor, because you're a nurse. You have to earn, though, your kindness with your behavior, with the way you treat them. Treat them with your behavior, with your interpersonal skills, with your kindness. You have to earn it. And what I'm saying in this slide is when you take kindness and you put it on top of competence and you put the two together, kindness and competence, you put it together, then you have a stronger influence on healing than competence, influence, trust alone. This is my hypothesis for you, my proposition. So, just in wrapping up with the last few slides, kindness, influence, trust encourages effective shared decision-making in which patients are well-informed and their voices are heard. It influences therapeutic alliance in which patients believe the clinician has their best interests at heart. It encourages relational strength between patients and their clinicians, contributing to patients and clinicians' sense of psychological safety in communicating honestly with others. Psychological safety is so important in healthcare. What that means is I feel safe as a patient telling you, my doctor or my nurse, the truth, my truth. And that you as a clinician feel safe in telling the patient or family member the truth. Again, gently, in carefully phrases and words, but telling them the truth. And continuing, kindness, influence, trust encourages improved patient follow-through on their treatment. It encourages reduced patient anxiety. It encourages less decisional regret after the decision is done, after the treatment is performed. It encourages more humane end-of-life care. I've done a lot of study on end-of-life care in my country, in the United States, and we're performing poorly. There's far too much overtreatment where we're hurting people at the end of their life with treatment that doesn't help them, it just hurts them. It just makes them sicker. It makes their life worse instead of as well or as good as it could possibly be under the circumstances. More humane end-of-life care. And finally, greater patient satisfaction and staff morale. So these are the take-home points. This is what we've talked about today. Kindness is multidimensional. It has these 6 dimensions. This comes from years of research that I've done on this topic. Deep listening, empathy, generous acts, timely care, gentle honesty, and support for the family. It's multidimensional kindness. It's powerful. Hopefully you've seen in my presentation how powerful kindness can be. And it's voluntary. It's discretionary. It's up to you. We decide in every single encounter we have with every other person we interact with at our work, our coworkers, our patients, their family. It's voluntary. We decide how much extra effort, how much discretionary effort, how much extra effort, how much volunteerism we are going to put into the service we are providing to another person. We decide. We make that decision. We are volunteers. Kindness can be a life vest in a sea of suffering. And finally, is the final slide. Care Human starts with and ends with kindness. I thank you very much for your attention today. I'm going to stop sharing my screen and hopefully we have a few minutes for some questions.
Bueno, vamos a dar inicio a la sesión de preguntas al doctor Len Berry. Yo me voy a permitir en este momento hablar en inglés para que él no tenga el problema de conectarse a la traducción, si es que está funcionando así. Hi Len, I'm sure that you're hearing what I'm saying. Can you tell me? ¿Hay alguna pregunta del público en este momento? Nada más hagamos un intento para saber si él está recibiendo la voz en la traducción y si no, aquí hacemos la traducción. Adelante. Len, just to let you know, we're going to receive the first question here in the room. So in case that you don't have the translation, I'll make it, but we'll try. Adelante, por favor.
Thank you very much, Dr. Barry. I have two questions for you. The first one is in your perspective of kindness, how can we deal with the problem of the overcrowded consults, the burnout of our physicians? We in Mexico have this problem that we have a lot of consults, a lot of patients, so sometimes it's very hard to maintain the kindness, to maintain the timeless, to maintain the deep listening. How do you have some words for us in this part?
Yes, I do. It's a good question. It's a fair question. Your work as clinicians is very hard work. It's among the hardest professions as clinicians that exist. And just like in your country, in our country too, we often deal with overcrowded waiting rooms, with too many patients, with less time to interact with patients than we would want to have. We would want to have more time than we have. But even if we have less time and even if we have more patients waiting for our attention, that is optimal. Even when we have very little time, and even when we have too many patients, we can still be kind. We can still be kind. And even if we have 3 minutes instead of 5 minutes, or 5 minutes instead of 10 minutes with the patient, that 5 minutes or that 10 minutes needs to be 10 minutes of kindness or 5 minutes of kindness, of gentle honesty, of listening as best we can. And when we run out of time, we explain to the patient as best we can how we can continue to help them, whether it's another appointment, whether it's having another member of our team who might have more time, whether it's our nurse or the medical assistant who can help with the visit, providing information, whether it's online information or printed information about the patient's illness so the patient can take that information home. But the fact that we have less time, it makes the word harder, but it does not give us an excuse to be unkind. We just have to try harder. We do the best we can. Our patients need us. They're dependent upon us. They're vulnerable. They need us to be our best selves.
Thank you very much. May I have another question?
One more.
Here in the National Academy of Mexico, there was a question made for one of the physicians, and the question was, in which part of the medical education we lost the kindness? In which part of the medical educations we try to play the role of gods or try to play the role of the leaders of the medicine? In your words, in which part we lost this kindness, or we lost this part of being human, to be a machine, to being a ChatGPT that has all the results, all the answers? Thank you.
Yes, it's a complex question. I don't have a full answer. The speaker who is following me, my good friend, Dr. Barish, that's a good question for him too, because he can follow up with me, but let me give it a shot. But let's ask that question again to Dr. Barish when he speaks. And that is that we, in too many of our medical schools in my country and probably in yours, we fail in medical training, medical school training, and in residency training. We fail to spend much time on interpersonal behavior, interpersonal skills, communication skills, and overall kindness to our patients and what that means. We're so focused on the science, and we need to focus on the science in order to be good doctors clinically, but to be a great clinician, you need to be more than competent. As I've explained in my presentation, to be a great clinician, you need to be both competent and kind. One without the other defeats the needs of the patient. And so we're failing in many of our medical schools. We're failing in many of our residency and fellowship experiences. If a new doctor who's just graduated from medical school gets a poor mentor, a poor role model, once they're in residency training, then we fail again. And we have to give our our newest trained doctors, we have to give them the best role models, the best teachers. And that's what you're trying to do, my friend Enrique, with your Care Human initiative, is you're trying in your country to move this forward, to put kind care central to a delivery of medical care rather than a peripheral, I'll get to it if I can, concern. You're trying to make kindness central. And that's what we need to do throughout all of our efforts in medical education, both in medical school, in post-medical education, and throughout our education in our entire careers. We have to continue to learn more about the possibilities of kindness.
Len, thank you very, very much. Unfortunately, we have to stop here. I really appreciate you to be with us this morning. Creo que podemos seguir compartiendo la pantalla del doctor. No ha terminado todavía esta sesión. Por favor, no lo quiten de la pantalla. So I'm not sure that you're listening now. But thank you very much for your time, for your wisdom, and for your friendship. We appreciate very much what you've shared with us. Muy bien, bueno, pues vamos a continuar esta sesión y tenemos también ya listo al doctor Paul Bayrish. Podemos ver la imagen. La seguridad de los pacientes. Ha sido director de calidad y director asociado de seguridad de los pacientes de la Universidad de Miami, en donde fundó el Centro de Simulación y Seguridad de Pacientes, y ha tenido posiciones académicas y de asesoría en Estados Unidos, Europa, Australia y Asia. Fue editor del British Medical Journal Quality and Safety y tiene más de 350 artículos y 5 libros. Paul, are you ready?
Hi, Enrique. Delighted to be here. Yes, can you hear me well?
Sure. Go ahead. Thank you very much for being with us.
Can you hear me? I want to just confirm. Yes. Can you hear me?
Sure. Yes. Sure. Yes.
Perfect. Thank you. It's a real pleasure to be here. Thank you, Enrique, for this invitation. I'm so disappointed not to be there in Mexico City. It's a great honor to follow my good friend, mentor, and luminary, Len. Thank you so much for that fantastic discourse. We are overdue to write this up. These are core issues that gnaw at me for maybe 40 years. Thank you for bringing that together in such a coherent and cogent manner. And I'll answer the question that Len was answered as well later on. The question really is, how did we get here? And does it have to be this way without being Pollyannish, without being squeamish about these core problems? Because these are existential problems. They're not simple by any means. So with that, I'm going to kick in and start my talk here. I'm having a problem with advancing my slides, but let me see what's going on here. I'm going to stop sharing for a moment and share again because it looks like my slides aren't sharing. Okay, so here's who I am as a brief background, as an anesthesiologist, as an intensive care physician. Been involved for about 25 years in running departments and hospitals and advising hospitals and organizations in the US and globally. In this talk today, I've been asked to talk about about human factors, and particularly the word, care, human, and human factors. And we'll talk about the alignment and the importance of those two terms. I have no meaningful disclosures to share relevant to my talk today. So I love this quote by Dr. Reles, this definition, what is care, human? I'm going to highlight the particular element, which is protect from harm, and talk a bit about that. I think Len covered very well the rest of this definition. And so I'm going to talk about what we mean by harm. And so in the last 50 years, we have lots of reports from high-income countries, low-income countries, including reports from Mexico suggesting that care is not as good as we think it is, that care can lead to harm. I'm not talking about lack of access to care. That's a separate type of harm. I'm talking about care that's delivered, but not delivered safely. I'm talking about care that's delivered, but without proper intention. I'm talking about care that's delivered that causes service harm, as Len discussed, that causes meaningful physical harm, that causes emotional harm, and causes deep physical and financial harm as well. We have lots of data. A few samples on the left is from North America, is from Boston. A good friend of mine, David Bates, showing that in the Harvard hospitals from the period of 2000 to 2023, almost a quarter of patients have measurable, preventable harm, right? So a quarter of care, remarkably, in fantastic hospitals. I trained in one of them for many years, and yet still a remarkable amount of what management would call, the business world, service failures. If the service is to deliver high quality, patient-centered, kind care, these are service failures, although here they just measured the physical harm. If you added that to all the kindness harm, to borrow a phrase from Len's discourse, then it's much, much more than a quarter. On the right is the largest study of its kind in Latin America. In this study, which looked at the complications after cancer surgery, and as you can see here, quite a bit of complications, 3 times as much in Latin America than in North America or in Europe. Here's another way of looking at this. This is Ara Darzi's work from London, looking at, this is data that's published by ministries of health, so with all the problems that go along with that, but this is the forward-facing, outward-facing data. For the sake of the study, the United Kingdom is 0 on the scale, and you can see the range of variation from Norway on the right of this graphic, and on the left is Mexico. By choice, they chose Mexico, and you can see that the 2.6 units, which is equivalent to 3-fold, maybe 5-fold difference. So the outcomes in Norway versus Mexico, using the same technologies, with the same training modalities, more or less, with the same internet and the same AI, has a 3 to 5-fold difference as measured by common standard defines patient safety. Here's another way of looking at this. This is some work from a team I work with, looking at avoidable mortality. And as you can see from the right, in this case, West Virginia, so the various US states, the average of the US is marked there. And on the left side are all the European countries or OECD countries. And again, you can see on the left, the least amount of avoidable mortality would be Lithuania. Notice the massive variance across countries. And the key message from this slide is we could do better, that there's a massive amount of preventable harm that's been normalized. And again, we're talking about all types of harm, although in this case, we're talking about death. We're not including the trust harm, the kind harm, the types of harm that goes even further that Len alluded to. The Joint Commission, which is active in Mexico as it is in around the world, argues that the top 3 causes of harm to patients are human factors, leadership, and communication. And so if I was in the room with you and I would ask the question, I'd be delighted to hear your comments in the chat box. How many of you have had a formal training course in human factors? So maybe in the chat box, if you can mark it out. Typically, when I ask this question in North America as well as in Mexico, usually about 3 to 5 people out of 100 say yes. It's very, very uncommon. It's not part of requirements in medical schools, nursing schools, public health schools, management schools, either in Mexico or in the US. So an extraordinary gap in education and training, which helps to answer part of the question that was posed to Professor Berry before. Here's some work that we did 20 years ago now, looking at, this is the first ever study published on wrong side anesthesia blocks. I was very interested in this after we had an incident that I later on talked about when I was on the Oprah Winfrey show. And this is the first ever study on wrong side anesthesia blocks. Although I was not to have the first wrong block, there have been thousands of them, but nobody talked about it and nobody ever published on it until 2007. And in this study, we looked at the databases in North America, in Congress, in the States, and what we found is that most wrong side cases aren't reported to the Joint Commission, and in fact, they acknowledge that only about 4% are reported. Subsequently, we put forward that there are about 3,000 wrong side, wrong patient, wrong level surgeries in the US, and that's never been disputed. Other studies have reinforced our findings. Parenthetically, I'll note that the last available data, which is the full year, which is 2023, suggests that in the US, there's been a 26% increase in wrong site, wrong procedure, wrong patient, wrong implant surgeries, even when all of them are using surgical checklists. I'll come back to why checklists are a tool but not a panacea. So another example, some work from Texas, looking at sponges left behind in patients over the last 7 years. This has been extensively reported by the Houston Chronicle. There's been no decrease in the number of things left behind in patients in Texas in the last 7 years. An extraordinary statement. And you can see there on the graphic the types of cases. They're much more common in thoracic and GI. The point, though, is that we're not learning. So maybe the question is not, why does this happen? The larger question is, how do we help healthcare systems learn more effectively? What does that mean for organizations like COFEPRIS in Mexico or CONAMED when they have to truly focus, what is the role of learning from adverse events? So for many, many years, I've been very interested in studying non-medical industries. I want to share a few thoughts about that. This is some work that I did with Don Berwick and Ram Liberty, again, about 21 years ago, in which we looked at how safe healthcare is as compared to other high-risk industries. And as you can see here, healthcare back then was so much more dangerous, but more importantly, as an anesthesiologist, I deliberately put this in, that inside the anesthesia space, which is considered to be the safer of all spaces in healthcare in general, there's a massive difference with the same people when they're dealing with an ASA1 patient versus an ASA3. There's a 1,000-fold difference in the same hospital by the same people, which is really quite dramatic. And this paper, which was a paper of the year by the Annals of Internal Medicine, led to a lot of conversations about why can't we learn from other industries about these domains. So what is human factors? Human factors in general is defined by this wheel on the right, including, as you can see, Len, it includes elements that you alluded to. So it includes how we treat people, how we think about the environment, the aesthetics, the stress, the trust, the moods, and of course it also includes harder engineering things like the building, the alignment, the equipment. All these things are part of human factors. So when we think about care human, it's interesting that play on words of the human here. And what does that mean? Most data shows that both in Latin America, North America, and Europe, about 3/4 of adverse care is related to non-technical skills. Non-technical skills, often under the rubric of human factors. This would include coordination, collaboration, truth-telling, trust building. All these so-called soft skills are not soft at all. They're harder skills. They're actually the hardest skills there are to train, much harder than technical skills to train, as it turns out. This is how aviation looks at it. They talk about software, hardware, liveware, environment. And so it's intriguing as we think about using this model that has been used to make aviation safe and nuclear power and manufacturing. How does it apply in a healthcare context? So I want to go back to the seminal giant of all manufacturing quality, which is Deming. And Deming, who was essentially a private consultant, who wrote extensively and was mostly ignored by a lot of industry in the US until MacArthur brought him to Japan. And in Japan, together with the Japanese world of Kaizen and the entire historical quality expertise in Japan, together came out with this model that he called the profound knowledge of improvement. And at the heart of it, to paraphrase Len, is the customer, always, the center of the system. And I think, again, another rubric to answer the question that was asked is, we do not teach, Len, in medical school that the patient is the heart of the system. We don't. And so until we do that, and if we do that, we often do it in a very tokenistic, very paternalistic manner. Other elements of Deming, the system, the variation, the change management, the trusting of the frontline staff, which I think is part also of preventing burnout. I'll show you that data soon, is that if we don't trust the frontline staff, we allow management to control what goes on in the operating room, in the clinic, in the pediatric clinic, we often get workarounds, gamification of data, et cetera. Again, to quote Deming, use the chat box. How many of you in your hospitals or health systems, it says on the masthead that your goal is to improve health outcomes? Typically, less than 5 out of 100 in my talks will say that this is part of the mission statement or the value guidance of their board or executives. Another key person to understand here is Jens Rasmussen, a giant Dane. Denmark is in the news today. They've given so much more than some people would like to think. Jens Rasmussen is the single most important person in understanding safety of high-risk systems, and healthcare, as we heard, is a high-risk system. And what Jens argued over decades and decades of work, what was ignored, by the way, by healthcare in Denmark as well, is that the human is the most important part of the human-machine interaction. And unless we understand how the human interacts with the system, we're often going to make the system more brittle, more dangerous. And again, some of these elements I hope we can talk about is how AI, while offer great potential, is actually making the system more brittle, more vulnerable in many ways. A corollary of that work is Pascal Carrion's work from Wisconsin, that if you think about the work system on the left, in the middle is the processes, on the right is the outcomes. So as we think about the care human that Enrique has led on, how does that fit inside of a social technical model? Where does that fit into that work system? The culture, the attributes of the physical environment, the cognitive leadership, the social cultural setting, Len alluded to the psychological safety that I'll talk about, all that is directly correlated to better patient outcomes, better professional outcomes, and better organizational outcomes. To put it bluntly, care that's delivered well and respectful makes you more money. The data shows that very clearly, and I'm glad to talk about that in the Q&A as well. For many years, Paul Batalden, the godfather of IHI, and a close friend and mentor, and a PhD supervisor of my wife, and the godfather of my son, the work on clinical microsystems is putting the patient at the center of the organizational approach. This is based on the Tuck School. Jim Quinn was a professor of business at the Tuck School who argued that all good businesses are based on microsystem-based approaches, so applied to healthcare. Why do we do what we do? Again, this is not taught in medical schools. So this is another rubric on why healthcare has still not really taken this to heart and truly transformed their education, their regulation, their oversight of health system providers. You're going to hear later on from Helen Haskell, and I'd be remiss not talking about the seminal work that she's done that's transformed the world of healthcare in her state in South Carolina, but also around the world. And her son tragically died because the staff were not clear about who's responsible for the work. They weren't transparent about their job. They lied. They didn't really respect the patient and Lewis's parents. Ultimately, that led to the first of its kind law in the world, where staff must wear name badges that states their hierarchy, and they must agree to call for help when a family says, we want somebody senior. Sadly, 15, 20 years later, some work that we've done in the UK called Martha's Rule. This young Martha, at the age of 12, died at King's Children's Hospital because the family said something's wrong, but the staff didn't listen. And she went on to die, and as of September, 4 months ago, all English hospitals have this new rule that says that if the patient member or the patient says, I need somebody senior and or I need somebody else, they must agree. They cannot put them down. They must listen to the patient who obviously, and the family who obviously has so much wisdom about their body, about the care, about the journey. So now briefly to Mexico. This is a project that I've been working on with a variety of team members, physicians and nurses and patients in Mexico. It's the largest cluster of adverse events in anesthesia in the world. Tragically, it's led to the death of dozens of people in Mexico and a few in the US, and hundreds of people that still suffer in Durango and Matamoros. So much of this work would not have happened without the leadership of patients and the community of family members that lost trust in the system. This is the report. So this is a fungal meningitis that was introduced via an epidural and spinal. This is the first patient in August 23rd, 2022, and ultimately, serious disability and went on to die later on. This case, which we've done a lot of work on in Mexico, are in conversations with CONAMED, and hopefully we'll get some more support to gain access to the data. What it suggests very clearly was not listening to patients, not following national and international guidelines for sterility, and ultimately black market use medicines and medicines that were carried by doctors, because in Mexico, anesthesiologists must carry their narcotics for many private hospitals in their car, on their body, and so often that poses all kind of problems. As you can see here, this has led to
Estoy escuchando una clase de México.
Many injured people. And can we maybe turn Ivan off? Thank you. And ultimately has not just been in Mexico, but also in the US. And there are multiple studies that we've done on this, and still ongoing on how to help transform the Mexican perioperative system based on these cases that we still do not know exactly what was the causes of this terrible infection that led to 57 deaths, 115 infected people that still suffer, many of them. And again, I'm glad to answer questions about this fungal meningitis that happened 2+ years ago. Again, we've been interviewing patients in Mexico using these techniques to better understand through the lenses of the patient lens. We've asked them about trust and kindness, as well as what actually happened to them and their families as they went through this process. Unfortunately, in Mexico, as in many countries, they wanted to blame, so they found the CEO and they decided to put the CEO in jail for 24 years, but we still don't have the underlying causes. And so while it might feel good to put somebody responsible in jail, this does not solve the problem, which still remains a potential source of harm, both in Mexico and beyond. So let's talk about what I call the 8 C's: the culture, the context, the constituency, the core need for championship to change the system, another element we don't teach in medical school, the role and importance of collaborators and networks, how we communicate, the coordination between the layers, and of course, the credibility. I'm so delighted, Enrico and Raul, that you're doing this under the auspices of the National Academy of Medicine in Mexico. I think that type of credibility is essential if we're going to get the professional societies and clinicians in Mexico and others to listen. So when we talk about culture, we talk about here's how we do things here. So we know that culture often is a source of adverse events. What does that mean specifically for patient safety? It means, how do we design a culture where the values and beliefs are embedded in how we do what we do, where the number one goal is, under all circumstances, our goal is to prevent harm, even if we lose money, even if we don't want to do that, even if any other constraints. This must be the number one reason why we are in the business. And that means supporting patients, supporting the comments that Len spoke about, kindness and truth-telling and trust building throughout the process. James Reason, another mentor of mine who sadly passed away last year, seminal work on what does it mean to actually change the culture. James was a student of Jens Rasmussen, wrote a lot about how the organizational culture, when there are problems, the last thing that a clinician can do is just say nothing or keep your head down. And so that means being informed about these problems, reporting these things. In Mexico, as in the US, very few clinicians report adverse events. Our studies suggest that as little as 10%, sadly. So that means that when you read a report about adverse events, a good study, you're only often sampling a small part of the problem because of other issues of people being afraid to speak up, because people don't really learn, because they're afraid of the consequences. Len alluded to psychological safety. This is Amy Edmondson's work, a seminal work from Harvard Business School, now nearly 27 years old now, the foundational work. It took about 20 years to get into medicine, but the role and importance of staff feeling safe to speak up as a human factor. So the care human here would be taking care of the human staff members that need to be feel that they're safe to speak up. So I highly recommend her book, The Fearless Organization, again, not being taught in medical schools. This is some work that I've done in Norway with one of my PhD students. We've been studying for 10 years the likelihood that a patient will have harm in Norway, which, as I showed you, has one of the reportedly best outcomes in the world. The chance that you will die in a Norwegian hospital is directly correlated to how well the staff feel about their work and how much they feel respected by physicians and management. Or to put it differently, if you want to increase the mortality in your hospitals, disrespect your nurses. Don't listen to them, marginalize them, don't acknowledge their work, and they indirectly, not directly, they're not causing the harm, but the system inferences that that type of action towards them leads to harm. So this is the largest study of its kind, 2.5 million people, catchment area, half of Norway. Love to take questions about that and the implications around culture and outcomes. I've been interested in culture, particularly in surgery as an anesthesiologist and intensivist. This is some work that we did about 18 years ago, looking at the culture in pediatric cardiac surgery with live observers in and out of the OR. We did this in the US, we did this in the Netherlands, we did this in other places. And what we found was that 1/3 of the people in every big case feels that one of the team members is not ready for the case. Either they're too tired, or they're intoxicated with drugs, or they're simply not up to par technically or otherwise. 1/3 in the best systems in the US in this study. We further, and this is work that we did in North Carolina, we asked patients of children that have cardiac surgery how to better improve the respect, the kindness, and the trust of them. And what the family said to us, Len, was the key thing that got them to trust the system was when the parents were taught to help support the care of their child. By them allowing, and this is one of the many quotes that we took from these interviews, by the family feeling that the staff trust them in an incremental way to be part of the process, that helped them grow a lot more trust and support and overall good feeling about the care of their child, independent of how the outcomes of the child was. That's a very important statement. Independent of the outcomes was how the family felt the way they were being treated by the staff when the staff was taking care of their child. A lot of good interest in this in the UK. This is some work that we've done in Wales. One of my fellows, Chris Sube, now in Singapore, looking at this idea of the upside down hospital. Again, another aspect that was asked before to Len, why is it not changing? Because we don't change hospital management practices. It's not really run this way. We don't really co-design with the input of patients. We don't really bring patients into the C-suite executive decision-making. They're not part of strategic planning, and more private equity that Len and I have spoken about drives so many of these decisions, and not the needs of the patient and the direct community in which the hospital is responsible for caring for. We've gone further. This is a very large study from Texas, from Methodist, 6,000 patients. In one arm, it was a natural surgical procedure, in this case, an elective knee surgery. On the other, we designed a tool, a digital tool with patients and families, and we asked them, Len, what type of technology would help
you feel more trust, more support, more engagement. And after we designed this over 2 years, we then followed these patients and we found 3 things. Number one, the patients felt better about the overall process by 28%. Number 2, the pain scores were down by 18%. Number 3, after 6 to 9 months, the readmissions to the hospital was down by 17%. In essence, by designing digital tools to enhance the elements that Len spoke about, kindness and trust and meaningful engagement, we got better flow, better service, better financial outcomes. So there is a clear correlation between the design of digital tools and enhancing outcomes by using the principles that Len spoke about. We've been mapping out processes in and around the OR for a long time, time motion studies, site layouts. We do this by observing teams, by working with patients and providers. This is the care human aspect of the staff and the patients participating in the design, doing process mapping, doing task analysis. These are things that often are not taught in medical schools. Even today, we do not teach fundamental engineering of how to map a process. I love this study from a colleague of mine in North Carolina, in which he discovered that when he asked surgeons and anesthesiologists how often do they lie to each other and game the system because they don't want to face the bad news to each other. For example, a surgeon would, even though there's blood loss, will not say there's blood loss. An anesthesiologist will often not say if staff is available. And it turns out that about 1/4 to 1/5 of the time, staff lie to each other, not because they're bad, because the system undermines their ability to deliver a truthful answer. Again, we do not teach this in medical schools. We don't train nurses, anesthesiologists, and surgeons together, and so we expect them to work together, but of course they can. This is what the engineering representation looks like of service mapping, something that I do a lot with several hospitals in the US and love to do more in Mexico, perhaps under the National Academy of Medicine, on teaching service mapping to doctors and nurses so that we introduce it into the hospital system. We've done a lot of work learning from other industries, again, on how to be better team players. Notice human factors is at the top, and process and teamwork and threat and error management, and of course, the culture of change that I've talked about. This is a key book that you might enjoy about this. My team for 20 years has been working on developing team training for doctors and nurses. We borrowed from Patrick Lencioni's work at Harvard that teams can only work well, again, the care human side of it, if they have trust. If they're not afraid to speak up, psychological safety, if they're not afraid to commit, and if they're accountable to their actions, that's when you get the best of results. Here's some data from the UK showing that when staff, Enrique, don't feel committed, don't feel engaged, more patients die. This is across 18 different studies in the UK. Here's another one from the UK, multiple studies showing that when staff do not feel engaged in the mission of the organization, there's more inpatient mortality independent of other considerations. There is a price to pay for delivering unsafe care to patients, but also not respecting the staff who don't feel supported, don't feel entrusted, don't feel kindness. In short, the violence of the work that takes a toll of the staff as well as to the patients. Here's some work that we did in Chicago, Julie's team, that Len knows well, and Enrique, in which we showed that a culture tool can predict surgical mortality. So we can rank order hospitals in Chicago based on the culture. Irrespective of any other aspects of metrics, is the culture is a marker for better outcomes or worse outcomes in some of the best hospitals in North America. A few words on team training. Another thing we don't really teach in medical school, so this is number 4, I'm counting, of the factors why, the question that Len was asked, why doesn't it change? We don't teach teamwork. We did this work 20 years ago, the knowledge, skills, and attitudes of teamwork in the ICU, in the recovery room, in the wards, in the operating room, all based on 3 things: trust, shared mental models, and communication. This is part of what has become known as team steps. At the heart of it is the culture change. No surprise, this work is the most measured team training tool in the world. It's been able to show an 18% reduction in mortality. There is nothing out there, anything even remotely close. So Enrique and Raul, I'd love to introduce team steps to Mexico with you. in a Mexican version, adapting it to the unique challenges of the private and public and all the rest. But this is a powerful technology of sorts that now is close to 20 years experience. It's being used in about 2,000 hospitals around the world, remarkably effective in dealing with these types of issues. I want to wrap up. A final model is high reliability models. This is Carl Weick's work, a giant of organizational culture and change from Michigan, who argues that if you want to have high reliability healthcare, you have to teach this. Again, this is not taught in schools of medicine, nursing, or management as it relates to healthcare. These 5 elements are essential for delivering it. This is what it looks like in our model. So we've applied this in 5 major hospitals in the US. Clear principles of business, clear practices for the CFO, the CMO, the CIO, and the CNO. The principles are leadership, culture, and improvement. This all comes from Deming, through Shohart, through all the work that I've discussed earlier, all coming together under a high reliability model. This is some work that we published now 12 years ago. We interviewed 100 senior executives from around the world, and these were the practices that they said are needed for high reliability outcomes. Again, problem number 5, we do not select executives for these skills. We do not hold them to account on these measures. This is not how regulators in Mexico or the US measure hospitals for performance. This is another key element why things don't get better. This is the British model for it from the Health Foundation. Learning systems. How do we use things from the system to engage differently, to hold differently, to measure differently? This is a model, I think, that we could introduce to Mexico as well, a model that needs to be customized and aligned locally. This is a tool that we use in North America for measuring culture in hospitals. I'd love to talk to Mexican clinicians online on how we could pilot this in Mexico. This is asked once a week, in which we get a clear sense of the culture on units. Notice, Len, that the most important thing there is the patient experience. All the other elements are part of this wheel of culture. We try to create this just culture. What does that mean in practice? That when clinicians try to do the right thing, we don't punish them. We support them, we engage them, we coach them. It's rare that you need to fire or discipline a clinician, and that's because they've been reckless. And we define recklessness by conscious disregard of risk. This is a rare thing in healthcare. Often, that's not the behavior that we're seeing. Here's some work that we've just published from Japan, a major hospital in Tokyo. We looked at 5 years of patient complaints, Len, and we looked at how often do patients and families complain versus how often do they send in notices of gratification and appreciation. And again, another element that we need to use more tactically and strategically to change practices in hospitals. So, 2 final thoughts on self-harm. We know that staff burnout in Mexico is a big problem. I was just there about 5 weeks ago. 44% of nurses want to quit. About half of physicians say they don't like their work. So it's important to remember this idea on how do we think about how all the things that are happening, in this case in Mexico, but it parallels North America, on how these things are influencing staff access, too much work per staff member, exhaustion. This is the translation to the surgical where I live. These 8 elements, we've been using this wheel in Mexico, the physical toll, emotional toll, spiritual toll. When we interviewed residents in Durango recently, we found out that less than 5% of the residents go to church. Less than 5% of them have exercise. Less than 5% of them feel safe financially. Less than 5% of them sleep well when they're at home. Many of them do not have stable relationships. How do you expect these people to grow and mature and be leaders in their community, delivering safe, trusted, kind care if that's the case? So this is a picture I took when I was recently in Africa, and these elephants are helping each other. We need to help each other change the healthcare system. That means patients and staff and management working together to transform this outcome. It means a safety management system. That means taught in medical school, held to account by regulators and administrators, and knowing the best and applying the best of manufacturing knowledge from Deming and Shohart and many, many other giants that transformed industry, including in Mexico, which is a powerhouse in manufacturing, but is rarely looked at as a model for changing healthcare. It means the fearless organization. Again, this great quote by Amy Edmondson. How do we help clinicians be fearless, to speak up and to tell the truth and not be afraid when they see aberrant behavior? It means using education, but education is the weakest tool to change outcomes. The most effective is redesign, better barriers, better mitigations. That's where the National Academy of Medicine can help out. That's where CONAMED and COFEPRIS can help out. While education and training is important, it's the least effective when it's by itself. It must be coupled with real systems engineering and changes in the models to engage and change. And finally, of course, at the end of the day, I learned this from Don Berwick, culture always trumps everything else. So unless we think about changing the culture, which means we need social scientists in medical school, in residencies, in regulators, to understand the need to change the culture in order to engage it. This is the paper we published, again, 20 years ago, in which we talked about the fact that the system will only change if we focus on the harmony and trust amongst the human actors. So the care human actors, if we modified that term, aligning with the amazing work that Enrique is leading on here, this idea of changing the way we socialize providers, the way we support them, the way we engage them, and the way we reward them in their organizational model. Final word, this is an organization I'm part of that focuses on helping children with heart disease. I highly encourage you to get involved with me or others if you'd like to participate. This is particularly focused on improving the outcomes of children with heart disease in Mexico and other low and middle income countries. So I'm going to end there. These are some books that we've published on this work. I'd be delighted to answer any questions by WhatsApp or by email. Thank you again, Enrique, for this kind invitation. And I look forward to comments and questions. Thank you.
Thank you very much, Paul. Tenemos espacio para una pregunta. Ceci, por favor. We have one question.
Hi, I am Cecilia Garcia, and I'm very interested in knowing which is the effect of kindness as a construct in burnout in caregivers. And the other is that if you have studies about psychosocial support to caregivers and what is the effect of these programs in healthcare and in outcomes.
Thank you. Yes. Yes. Not here. Salutations.
Andan mandando aplausos y yo no entiendo nada.
¿Quién está controlando en cabina esto?
Maybe I can ask a question. Would that be okay, Enrique?
Yes, please. Go ahead. Can you hear me?
So my question, I don't know if Raul is also in the room, Enrique. I can't see anybody but you. But how do we get the National Academy of Medicine work on these things, can together advance these ideas? And given the challenges in Durango 2 years ago, we had another example of a terrible death of a young girl from plastic surgery in Durango a few months ago. These examples of system-based human factors change management. How does the National Academy of Medicine help to lead on this, and what can we do to help them move this forward?
Sure. Paul, before we can answer that question, can you wait a bit? ¿Es posible que pongan orden allá atrás? ¿Ya? ¿Está de acuerdo? Paul, did you hear the question from Dr. Cecilia García Barrios?
Qué guapo se ve. ¿Cuál?
Not
You didn't hear the question? Parece ser que no escucha.
Paul, we will going to use a very basic technology because the sophisticated one is not working. So, aquí tengo en el teléfono al Dr. Paul Barish. So, could you make the question directly?
Okay. Can he hear it from the telephone?
Not.
Yes? Okay, thank you. I'm Dr. Cecilia Garcia, and I'm very interested in burnout. And you were talking about burnout in Mexico, that it's very, very high. And my question is there the influence of being kind and all this construct of kindness in burnout in the caregiver? And the other question is if you have social support programs for caregivers, and what is the influence of having these programs in outcomes, patients' outcomes?
Thanks for the question. So hopefully that was. Leave me here. All right, that's okay. So we know very clearly that lack of kindness, lack of trust leads to burnout and bad outcomes. We know this for a fact. We also know that burnout has never been worse than in the last 5 years. Careful studies done in North America, as well as in Europe, as well as in other places, suggest that we have an existential crisis. Our staff isn't happy. Our staff is harming itself. Our staff is consuming more drugs, more alcohol, more marijuana, more cocaine. We know that we have an extraordinary problem, and I connect all these things together. And so we need to support these efforts for burnout reduction, and we need to support those people who do so. Clearly, some people are better than others in helping others. So just like some people are better than others in being pastors and priests, equally, some people are better than others in being empathetic towards their colleagues. We can do this. This is possible, but it has to be a priority. The solution is not to open up more nursing and medical schools. This is not the solution. We are hemorrhaging more and more staff from more and more schools. In some programs around the world, 30 to 50% of the graduates want to quit medicine and nursing. It's dramatic. The answer is not more schools. The answer is dealing with the people in the system who are passionate about caring for others, who came there for the right reasons, and for a variety of reasons have lost and have soured on those intentions. This must be a national priority. It must be manifested in reward system. It must be manifested in regulatory system. And it has to be part of how we train people. I was not taught one word about burnout when I was in medical school, nor in residency for that matter. There is more conversation now, but it's not a structural thing that is part of all levels of training and support, and it's certainly not connected to long-term viability of staff as they mature and grow in the system. So we have much work to do there to take the research and implement it in systems and practice. I hope I answered that question.
Thank you very much, Paul. I'm sorry we'll have to stop here. Of course, there are many questions, among them the one that you made about the role of the Academy, which I would leave to our president to answer, and perhaps in a future conversation with you. You both know each other very well, so we'll have a chance to discuss the role of the National Academy of Medicine in these matters. So thank you again, Paul. We'll see you soon. Muy bien, tenemos considerado un espacio para preguntas y respuestas, para descanso, y a pesar de que fuimos construyendo espacios en la agenda, si ustedes se fijan, algunas sesiones no empiezan inmediatamente después, precisamente para dar estos colchones, pues se nos agotó el colchón con el retraso que tuvimos esta mañana inesperado y se nos ha comprimido el tiempo. Yo les propongo que si tienen ustedes la bondad nos permitan continuar, porque está conectada la señora Helen Haskell y creo que es muy importante escucharla. Desde luego, ustedes tienen libertad, está fluido el espacio para que puedan tomar un café o hacer un momento de descanso rápido, pero tendremos que continuar con Helen Haskell para no seguir retrasándonos. Y quisiera saber entonces, sé que ya está conectada, ¿podemos poner su imagen, por favor? Hello, Helen. Helen, can you hear me? Can you hear?
Yes, I can. Yes, I.
Helen, thank you very much for being with us. I have spoken about you, and I can say again how much I admire you as a woman, as a mother, as a leader. So we appreciate very much you to accept this invitation to be with us this morning. So please go ahead with your presentation.
Okay, well, thank you. Thank you very much, Enrique. Well, I am an American patient advocate, and I'm here to talk about the patient perspective about what it means to care. What exactly does it mean? What do patients consider to be caring, and what makes something care human in the eyes of a patient? So next slide, please. Let's see if I can do it. Okay, good. So I'm going to, this is a story of my own family. This is my son, Louis Blackman, who died at the age of 15 in a large teaching hospital in the U.S. It's not really the story of Louis, it's the story of the last 4 days of his life, which are the reason that he died at age 15. Just to give you a little background, because I think it's important, Louis was really a remarkable boy, at least in our eyes. He was a very high-scoring student, the highest in our municipal area. He was he had a wide range of interests and talents, as I guess a lot of young teenagers do, but he was funny, he was kind, he was unassuming, and he was knowledgeable about almost anything you could ask. We thought he was just on a different plane from other children. Next slide, please. But our perfect child had one imperfection, and that was, that's done one. Next slide. There we go. That was a condition called pectus excavatum, where the breastbone doesn't grow straight and it leads to sort of a concave appearance of the chest. It's pretty common, and Lewis's condition wasn't very serious, but we had seen an article in the newspaper from a teaching hospital near us talking about this safe, effective new surgery, minimally invasive with an easy recovery. And we went to our pediatrician, one thing led to another, and we took Louis to the hospital to have his pectus repaired. As far as we know, the surgery went fine, but as soon as he was in recovery, we discovered that he was not urinating and had not been apparently the entire time. He was given by the resident prescribed opiates. There was a heavy regimen of opiates. It was not as pain-free as it had been advertised, and as well as an adjunct dose of ketorolac, powerful NSAID, which is widely used, as I'm sure you all know. But he was not urinating, which is contraindicated for Toradol, and was given prescribed a very low dose of IV fluids by this same resident, something appropriate for a very small child, not a teenager needing replenishment. It took us a day and a half to get those orders changed, in spite of cornering everybody who came into the room. People were reluctant to challenge orders that were already in existence. But apparently the damage had been done, and another day and a half later, Lewis suddenly, right after a dose of ketorolac, Lewis suddenly developed an excruciating pain in his upper abdomen, in the area of his stomach. And the nurses and residents, it was a Sunday, they were not the regular crowd. They did not respond to his worsening vital signs over the next 30 hours. He stopped urinating again, his pulse skyrocketed, his blood pressure dropped, and he looked terrible. He was sweating, he was in acute pain, and the nurses were convinced that it was an ileus from the opiates that he was taking, and that he was being dramatic, that he was anxious. When he died the next morning, they were astounded. And an autopsy showed a giant perforated ulcer, a type that's usually associated with insane overdose. That's the short story. But the backstory is really all about human relations. So first of all, we had really fragmented care. The staff did not seem to know each other. They were performing tasks rather than providing care. No one took responsibility for the entire patient. When I got Lewis's records after he died, I tore into them trying to find out who was in charge of him. And it was baffling. I finally realized no one was in charge. The attending physicians were distant. They were not on the ground. Theoretically, they were in charge, but in actuality, no one was. Staff were focused on each other more than patient care. So they were listening to each other. When the nurses came up with the idea that this was an ileus, even though the symptoms really did not fit, it was just carried on by everyone. So they were listening to each other, not listening to the patient and family. And there was fear of speaking up, I feel sure. It seemed evident to me. There was one intern who was the only pediatric surgery representative in the hospital, and she was fearful, I think, of the resident. There was no psychological safety. They did not, and people who looked at him and knew that he was in serious trouble did not tell us. That was both nurses and doctors. They did not interfere with a patient who was not their patient, even though he was clearly at risk of dying. And they were standing on status. One of the defining moments in this stay was when I asked for an attending physician. The resident came in from outside the hospital and did not let us know that he was not the attending that we had requested, and followed along with what the nurses had said. There was no one dared say, I don't know what this is, we need to look further, because they were afraid of looking further, in my estimation. Next slide, please. So, what happened after this? We were sent home. Our firstborn child had just died in a mysterious way, unexpectedly. We were sent home. We were waiting for a call. We thought this would be a matter at least of some interest to the hospital, and probably consternation that a healthy child had died in this manner. We heard nothing, which is typical for patients because hospitals fear liability. So after the autopsy, Lewis's surgeon had told us that the autopsy report would be back in a month and he would call us. Well, he never did. So we called and we went down there. Next slide, please. And when we went down there, he said, well, we don't know what happened to Lewis. And by that time, we had done a lot of research and talked to a lot of people. And we knew what had happened to Lewis. And so we said, well, we know. And we told him what had happened and you know, what we thought had caused it. And he was very forthcoming. And he said, this is our fault. You know, our system broke down. Don't take this on yourselves. So we had a positive relationship with the pediatric surgeons at the hospital. We were all sort of feeling our way. No one had ever done anything like this before, but they didn't come up with really comprehensive solutions. They could not actually bring themselves to see it as a real system problem. They saw it more as a drug problem. Once the particular way that we're using that particular drug. And they would not let us talk to the residents, which was important to us because they had become the most important people in Lewis's life. We wanted them to know about him. We wanted them to learn from it. We thought we might be able to give them some closure, but it didn't happen. It has never happened. Next slide, please. Next slide. Yeah. So this is what they did. They pushed for the autopsy. I had resisted because I did not want to hurt my son anymore. They listened to us. They met with us. They settled without litigation. They apologized. It was, all in all, as positive an experience as that could be. Next slide, please. And what happened then? This led to really a statewide consumer-provider collaboration. We passed patient safety legislation. The state endowed a chair of patient safety. We had statewide patient safety programs, and both I and the people that I worked with went on to work nationally and globally in patient safety. Next slide, please. So, you know, that seems like a happy ending, but of course it's not a happy ending because it was based on a terrible and frankly needless tragedy. So my question is, what would Carehuman have done to change outcomes like this? There's the definition, which I'm sure you've already seen, honest, kind, trustworthy, and respectful professional relationship. And these are the 6 key elements of Code Human. So which one of these, I mean, all of these, of course, played a role in Lewis's care. The observations, for example, the seeing, the nurse was taking his vital signs regularly, frequently, but not acting on them, even as they continue to deteriorate. The listening, I could go on and on about that. I think that honesty is a real element in all of this. They were not listening to us, and maybe listening too much to each other. And this is a real issue with patients. Next slide, please. So Edgar Schein talks about humble inquiry. Little mouth, big ears, as one of my patient safety colleagues calls it. Asking questions that build relationships based on curiosity and interest, and the recognition that others know things you might need to know. He says that asking the right questions is more important than making recommendations. Next slide, please. For patients, this is the top concern. These Plaintree hospitals had 30 years focus groups, both by them and by the Picker Institute. And these were the top 3 complaints that patients had over all these years. The top one was dismissal and not listening. Every survey I have done or seen with patients, almost every survey, I've now seen one that had not listening as the top concern of patients, not being listened to. There's a whole literature about it. Really, it's more hand-wringing than anything else. People don't know what to do about not being listened to. Next slide, please. People are taken by surprise when they're sort of met with dismissal, which I think is usually caused by by lack of time. The providers are just running from pillar to post, and they don't want to stop and take time for a conversation. But medically harmed patients consistently see disrespect and dismissal of their concerns as a major cause of their medical harm. People, obviously, we're social creatures. We live in a social network. If the social network breaks down, we feel that the entire network has broken down. And I think that is probably the case. Next slide, please. This is just another one. I always like this, Leo Tolstoy's novel, Anna Karenina, starts out, all happy families are alike, but every unhappy family is unhappy in its own way. So Thomas Lee is saying here that all health, if you show courtesy and respect, patients trust you, but you can lose it in any number of ways. But to gain it, you must show courtesy and respect and listen. Next slide, please. So what are you listening for? You're listening for knowledge, right? And Stephen Spear puts forth the proposition that all problems are caused by ignorance, by somebody not knowing something that they needed to know. Might be something very small, might be something very large. Ignorance doesn't. Next slide, please. And he's saying that the most important point is to not be afraid to speak up, to say, I don't understand, please make it clear to me, please help me. Next slide, please. So the knowledge, information, this goes both ways. Patients you ask questions of patients, but patients need information too, and they're not always going to ask, they don't even know the questions to ask. But they need to know what's going on there in an alien environment that they do not know much about. They have to navigate and make life and death decisions. They need information. And just giving people information, whether they ask for it or not, is very helpful. Gives them a sense of control, it relieves fear, promotes partnership. People need just basic things aside from information about their medical condition. They need to know how to navigate the hospital system. They need to know who's who in the hospital. They need to know the signs of the danger signs, what can go wrong, whom to call if it does. People don't know any of those things. And I can tell you there is nothing more terrifying than having no one to call in the hospital. So all of this is based on the Picker principles of patient-centered care, respect for patients' values. I won't go through all of these. Picker started in the 1990s with the concept of patient-centered care and really revolutionized everything in a lot of ways. The To Err is Human report by the Institute of Medicine in the U.S., and its successor, Crossing the Quality Chasm, they were based on these Picker principles. And patient care, so they talked about patient-centered care. That is, being respectful of and responsive to patients. Next, they talked, patient engagement was a sort of step up, talked about patient public involvement. Next, and influencing patients, helping patients influence their own decisions. Next slide, please. Next slide. Yeah. And now we have co-production, which is patients working together with their healthcare providers to decide their own healthcare. I think, and this is all progress, and we still call it patient engagement most of the time, and patient engagement has come a long way. Certainly, patients are welcome, and myself included, I feel it, in a way that we were not even 10 years ago. But there's still something more, and it's not that integrated network that I was talking about earlier, that where everybody is sort of working together and on the same page. Next slide, please. So what patients want, above all, safe, professional, respectful, compassionate care. Next slide, please. Leading with curiosity and humility, embracing uncertainty, not being afraid to speak up, and communicating clearly, honestly with the patient and family. Next slide, please. So these are just a few things that patient input from the patients is critical to this network. Reporting of safety events and hazards, which I think we're finally getting somewhere with. There's several of these programs now where patients can report in real time. And in the US, they can also report into their patient portal. Next slide, please. And patient reporting is critical. Clinicians routinely downgrade symptoms more than patients, but the patient reports actually correlate better with functional status than the clinician reports. And patients whose treatment was adjusted according to patient-reported symptoms, cancer patients had better survival rates. Next slide, please. And in terms of revealing errors and near misses, there are many, many reports like this showing that patient reporting covers a lot more than is reported anywhere else in the medical record or in incident reports. Next slide, please. So the patient needs to be a member of the team. These are initiatives that can be implemented to do that, to have this continuous flow of information to and from the patient. People need to know who's who. They need to be empowered to speak up, have a bedside change of shift and family-centered rounds where they can ask questions and provide information. Next slide, please. One of the critical ways they can do this is by family escalation of care, having a way to raise the alarm, as I did not. Next slide, please. This is Mary P. Mills and her daughter Martha, who died in a very similar way to Lewis 3 years ago now, I think. And they have started, next slide, please. Next slide, please. They have started a patient escalation of care program in the National Health Service in the UK. And that's because I just wanted to have this slide for background. But, this is an old study with the comparing hospitals with the highest death rates with hospitals with the lowest death rates. And what is striking is that their overall complication rates, even their major complication rates, are very similar, but their death rates are strikingly different. And that is response. That is the care that is making the difference. And that's what patients really see. So Martha's rule is intended to, it has 3 components. Patients report their own progress daily in the medical record. Outreach nurses check in on the patients, and then they have a number to call if those 2 things are not sufficient. Next slide, please. Here's the patient wellness questionnaire, pretty simple. How are you feeling? And how are you feeling compared to the last time we asked you, which usually is the day before? And you can detect a trend, detect deterioration much earlier than it's picked up in vital signs just by asking the families these questions. Next slide, please. And then, if there is a rapid response call, get the family's evaluation. Why did they call? What happened before they called? So that you can have a record of what goes wrong and how to correct it. Next slide, please. Once this happens, if mistakes happen, everyone needs to learn together. You cannot learn without patient input. Patients are the only continuous thread. They are uniquely motivated to find out what happened. They have nothing to hide. They are your best source of information in many, many cases. Next slide, please. And what we're dealing with here, overall, is really uncertainty. People don't want to admit that they don't know, but uncertainty is an integral component of medicine. As Jerome Grootman says here so eloquently, without uncertainty, there would be no judgment. It's how you deal with it that makes you patient-centered or not. Next slide, please. So I'm really going to end with this. My question was, how do you make care meaningful? What does being caring mean? I think that Victor Montori, who's got a program very similar to Care Human, has expressed it very well. It's care that's safe, makes use of best medical evidence, and grapples with the uncertainty. It strives to see patients as individuals, including everything about them, and unites patients and caregivers and clinicians as partners in that network, working through the health situations to find the best course of action for this person at this moment in time. Next slide, please. Thank you very much. That's my talk. Whoops.
Helen, thank you very, very much. We'll open the floor for questions. ¿Tenemos preguntas para Helen Haskell? Yo puedo hacer una mientras alguien hace alguna más aquí en el auditorio de la academia. Helen, I'll start by asking you, how has been the response from health professionals towards your initiatives? Do they feel threatened, or do they feel that they have collaboration from patients, and in your case, from a family from patients? What has been the response from health professionals to all that you've done so far?
I have generally had a positive response, but maybe I don't know what goes on when I'm not there. I don't know. I think I've seen not positive responses to some of these initiatives, often from young doctors, from residents who really don't sort of comprehend maybe some of the issues. And I think, they're young people who don't yet have families and don't necessarily know the pain of, they don't know sorrow yet, often. sometimes I think that's the case. So that may be too broad a brush, but I think that in general, people are receptive in theory. On the ground, I'm not so sure.
Good. ¿Alguna otra pregunta? Adelante, hermana, por favor.
Creo que muchas gracias por su ponencia. ¿Cómo perder el miedo a preguntarle al paciente sin el temor de que por algún error médico podamos ser demandados?
Did you get the question in English, Helen?
I think the fear has been blown way out of proportion. Medical malpractice suits are pretty rare. In the United States, they're almost impossible to bring. It's sort of a myth that that you're likely to be sued. I think it impedes learning. And I see in places such as Ontario and Canada where it's almost literally impossible to sue, I don't see any difference in the attempt to hide things. I think that it has more to do with status and shame than it does with fear than it does with anything monetary. I think there's a lot that goes into the identity of being a doctor or a nurse that is threatened by the thought that you might have made an error. And I think we need to just not look at them maybe as individual errors. Sometimes they are, of course, but as Paul was just pointing out, I mean, there's so many things that underlie an error, any error. I don't know if that answers your question, but I think that you should not worry about being sued.
Well, they say yes, you answered the question. Helen, we have to stop here, unfortunately, and I thank you very, very much for your time and again for sharing with us all your experiences, which are in fact very moving, but at the same time, they help us to think from the other perspective, the most important perspective, the perspective from the patients and family perspectives. So thank you again. Look forward to see you soon. Vamos ahora a concluir y ahora sí, tenemos unos minutos para descansar. A las 12:45 en punto tenemos la última conferencia de esta mañana. Así es que tendremos algo así como 8 minutos para aprovecharlos. Aquí nos vemos. Maureen, welcome. Can you hear me? Creo que no me está escuchando. ¿Podemos revisar el sonido, por favor? ¿Tenemos ya sonido allá? Maureen? ¿Ya? ¿Ahora sí? Maureen, can you hear me? ¿La podemos ver en imagen, por favor? ¿Qué pasó? Pero no me escucha. Pues no, pues ¿cómo? Maureen, can you hear me?
I can't hear.
Yeah.
I can't hear.
Yeah.
I can't hear.
Yeah. Okay, Maureen, can you hear me? Can you?
Can you hear me okay?
Yes, we can. Yes. Can you hear me? You hear me?
Enrique?
Yes, Maureen, we are trying to solve.
Okay, I'm ready.
Good. Well, Maureen, thank you very much for being with us. I appreciate very much your time. So we can start now. I've mentioned about your background, your fascinating background and your leadership. So please go ahead.
Hello, welcome to our session this afternoon, and I'm delighted to be here with you. I wish that I was there in person, but we'll share some examples for you today about how caring and kindness can make such a difference in healthcare. The work that you are all doing is so important for many, and I really see you as global role models. So I'm excited to learn from you and to continue to share all the work that you are doing together to make a difference in health and care. I wanted to start with a story. I'm the oldest of 9 children, a big Irish family, and this is my brother, Johnny. He was the third in the family. Johnny was an amazing kid, as you can see, handsome, smart, and really, really kind. He was the ball boy for the Boston Celtics in the front row. He was the 4th from the left, and was an amazing, accomplished person at his young age. When he was 17, right after this picture was taken, my brother was diagnosed with Hodgkin's disease. And I was a young nurse at the time, and he kept coming up to my apartment to say how worried he was about his health. And I thought, as a young nurse that my job was to give him hope. So I would tell him, no, there's more radiation, there's more chemotherapy, there are all kinds of new things that will take care of you. But Johnny knew better. And when
tenía el conocimiento. Cuando fue al hospital en una ocasión, estaba en cama, llegó el doctor y todos los doctores alrededor de la cama dijeron, bueno, a fin de cuentas todos sonrieron y luego cuando regresó dijo, Johnny, ¿qué quieres? Y mi hermano nos dijo, quiero irme a mi casa. Entonces llevamos a mi hermano a casa, pueden ver lo enfermo que estaba, tuvo un muy buen día de acción de gracias con nosotros, hicimos un pastel que tenía forma de pavo y pasamos 2 semanas maravillosas con él. Yo le dije cuando llegó a casa, Johnny, ¿qué quieres? El doctor me dijo que esto importa, saber qué quieres. Y me dijo, Johnny, quiero cumplir 25. Y este es justamente su cumpleaños número 25, 4 años más tarde falleció. Tuvimos varias semanas maravillosas que pasamos con él, que nunca habríamos tenido si el doctor no le hubiera preguntado, ¿qué quieres, Johnny? Y él quiso ir a casa. Esto me enseñó que tenemos que preguntarle a la gente qué importa para ellos. Y también se estaba hablando hace rato sobre la idea de las diferentes formas en el pasado, donde hubo un pediatra en el público, en donde realmente nos relacionaba con lo que hablaba yo de la amabilidad, la compasión y cómo podemos marcar una gran diferencia en el área de la salud cuando cambiamos nuestra cultura. Todo el trabajo que ustedes mismos están haciendo y que han realizado con los años, conjuntamente, individualmente, puede marcar una diferencia. Así pues, Bob Clever me llamó posteriormente y dijo, ¿podemos reunirnos? Dijo, estuve aquí, estuve escuchando tu presentación y bueno, yo soy pediatra, eran cuestiones un poco aisladas y yo enseño sobre temas médicos, pero al final de que escuchó mi presentación dijo, quiero reunirme contigo, tenemos que hacer cambios. Así pues, reportamos al reporte del Instituto de Medicina y vimos los diferentes aspectos de la definición de calidad. Y nosotros dijimos, la única forma en la que verdaderamente podemos mejorar la calidad es juntarnos, reunirnos en todas estas áreas e insertar el tema de la bondad. Así se inició el movimiento La Bondad en la atención de la salud.mundo. Kindness in Healthcare.world. Y entonces teníamos reuniones, nos la pasábamos muy bien trabajando en estas reuniones y decidimos que queríamos seguir continuando en estas reuniones. La última lámina, vamos a ver al final, una liga para que participen en estas reuniones mensuales que tenemos. Tenemos participantes de todo el mundo que participan en donde cuentan sus anécdotas, el impacto, la investigación, la felicidad en la fuerza de trabajo, la experiencia de los pacientes que estamos queriendo entregar. Les invito a que se unan a estas llamadas mensuales. Hay gente que se inspira, dicen, donde pueden obtener ideas, motivaciones para poder introducir los cambios que queremos hacer. Existe también un valor estratégico en la bondad. Lo número uno que yo escucho en todo el mundo es esta necesidad de confianza, de colaboración. Cuando se dio la pandemia de COVID, yo entrevistaba a los pacientes de diferentes partes del mundo y yo les preguntaba a los pacientes que entrevistaba, ¿qué ves como algo positivo en el sistema de atención a la salud? Y también hablábamos de los grandes retos. El reto número uno que encontraban ellos era esta idea de confianza, colaboración, trabajo en equipo. Decían que muchas veces están hablando con un especialista que se enfoca en un órgano y otro especialista va a hablar con otro lenguaje totalmente diferente de otro tema. Esta idea de trabajo en equipo creo que es de gran importancia para nosotros y realmente nos lleva a ver cómo podemos cambiar el mundo de la atención a la salud. Es importante, realmente esto empieza con el tema de la educación y es un ejemplo maravilloso de la escuela Dell, en donde los estudiantes se reúnen y dicen, nosotros vemos que hay un valor estratégico en la bondad. Sin embargo, nuestro sistema no actúa de esa manera. Por lo tanto, recreamos el modelo de visitas de atención primaria para que uno no llegue, esté esperando en la sala de espera, pasa a otra sala en donde tiene que seguir esperando como paciente. Se rediseñó el sistema de atención para que uno llegue a un equipo y el equipo de salud viene, en donde pueden tener un impacto, la recompensa en el impacto de la salud es maravilloso. Si pensamos en este valor estratégico que tiene la bondad, nos da la energía para rediseñar la experiencia del paciente y también para proporcionar que nos dé esta experiencia laboral que la gente necesita tanto de manera desesperada en atención a la salud. Voy a compartir mis láminas y ustedes podrán ver por su cuenta este video. Este video breve tiene que ver con el poder de la observación, el poder de escuchar, de entendernos unos a los otros. Esta será una herramienta que tal vez ustedes puedan implementar en su centro de trabajo, porque es muy divertido ver cómo una interacción de alto nivel generalmente no va a desarrollar la introspección, la información y las destrezas que se requieren. Ahora que tenemos este movimiento, más de 37 países, la atención humana en la atención médica ha permitido inspirar a muchas personas. Todos aprendemos de diferentes culturas, de diferentes idiomas, y ahora están traduciendo de regreso esto, lo cual ha marcado una diferencia para personas en todo el mundo. Y quisiera centrar la atención durante un momento en una de las lecciones que hemos aprendido, el poder que tiene el escuchar. Resulta ser que escuchar en realidad es parte del aprendizaje profundo sobre otra persona. Esto viene del escuchar a profundidad. He estado viendo, ahora que he aprendido más sobre este tema, he estado observando cómo la gente escucha, ya sea con la familia, ya sea en un supermercado, cómo se pueden ver estos hábitos que alguien los está practicando cuando los conoce. Escuchar, número uno, es descargar información. Simplemente tiene que ver con reconfirmar lo que ya pensábamos inicialmente, pero también claramente tiene que ver con escuchar como parte de un hábito de lo que ya sabemos. Escuchar, número dos, es los hechos. Cuando estamos escuchando en nivel 2, estamos abriendo la mente, estamos notando las diferencias, nos puede ayudar a confirmar o desconfirmar lo que ya sabíamos. Escuchar, número 3, es escuchar con empatía, abrir el corazón. Esto se ve, se aprecia a través de los ojos de otra persona, cuando se crea una conexión emocional. Escuchar en el nivel 4 tiene que ver con algo de escucha generativa, tiene que ver con una forma de cambiar de los deseos a futuros para aprendizaje profundo de uno mismo, pero también nos estamos abriendo a nuestro ambiente. Por lo tanto, yo los conmino. La próxima vez que estén escuchando, pónganse a pensar en qué nivel de escucha se encuentran. ¿Hay alguna forma en la que puedo practicar? Recientemente tuve la oportunidad de dar una presentación, de hablar, mejor dicho, con una persona del aseo en un hospital americano. Y me decía que lo habían despedido a este trabajador de la limpieza porque había tenido ausentismo varios días. Y me dijo que había acudido a recursos humanos, le explicaron que lo habían despedido y cuando regresó para sacar todo lo de su locker, al abrir el locker dice que se puso a llorar y otro de los trabajadores de limpieza le dijo, ¿qué te pasa? Y le explicó, me acaban de despedir. ¿Por qué? Bueno, pues porque muchos días me reporté enfermo y tuve mucho ausentismo. Y dijo, ¿por qué estuviste ausente del trabajo? Y ya había escuchado que la gente dice, ¿qué importa? ¿Qué es lo que importa para ti? ¿Qué es importante para ti? Le preguntó. Y le contestó, estoy pasando por un terrible divorcio. Si no voy al tribunal, perderé la custodia de mi hijo de 5 años. Y eso es lo que importa para mí. Entonces, la otra compañera de trabajo puso un papel en el papel donde dice, ¿por qué no nos enfocamos en lo que importa para cada uno de nosotros? Y él escribió los días que quería visitar a sus hijos y ya todo el mundo empezó a hablar de lo que era importante para ellos. ¿Qué era importante más allá del trabajo? Y luego fue con los ejecutivos y dijo, si yo les prometo que no vamos a costarles ni un centavo más y que vamos a tener el personal necesario para cada unidad. Nos permite que nosotros cambiemos la configuración del personal de limpieza y cambió la cultura porque empezaron a utilizar lo que era importante para cada individuo. La bondad es ir más allá de ser amable. Es un antídoto para el estrés y todo esto que estamos sintiendo en nuestro trabajo cotidiano. Realmente es un camino muy bueno para llegar a la satisfacción, el disfrutar del trabajo. El Instituto IHI ha hecho mucho trabajo, IHI, de lo que implica la amabilidad. Y uno de los fundadores de IHI escribió este artículo con su hija Maureen años atrás, dos médicos, uno general, un médico general y un pediatra, en donde se dieron cuenta que cuando hacemos un codiseño de la atención, teniendo en cuenta al paciente, estamos creando mucho mayor eficiencia. Estamos creando un servicio de atención a la salud mucho más efectivo. Por lo tanto, me he vuelto una defensora ferviente de pensar en la coproducción del servicio de atención a la salud, porque esto mejora el servicio. Las destrezas esenciales para ser humano, como lo dice en el New York Times, solo 30% de las personas en el mundo son buenos para hacer preguntas, son buenos para escuchar. Por lo tanto, las destrezas sociales de la curiosidad sobre otras personas son importantes. Siempre hablo de las destrezas que se necesitan para trabajar. Aprender lo que estamos aprendiendo hoy en esta sesión maravillosa, el IQ, el entender las emociones, el énfasis, que es aquello por lo que las personas están pasando, y CQ, el tener curiosidad, ser bueno para escuchar, marca una diferencia en el mundo. No sé si han leído este libro que se llama Compassionómica de los médicos, en New Jersey, en los Estados Unidos. Steve Tresiak y Anthony Mazzarelli, que hablan del impacto de la bondad en la atención. Esto quiere decir que el impacto es increíble cuando uno tiene compasión y amabilidad. El paciente le baja la presión sanguínea, puede reducir el dolor, los síntomas del catarro, reduce el tiempo para cicatrizar una herida. Esto es increíble. Entrevistaban a un anestesiólogo que salió del quirófano antes de que entrara el paciente y entonces puso el brazo sobre el paciente y dijo: soy el doctor fulano y seré el que administrará anestesia para asegurarme que no tenga dolor, que esté cómoda y que esté cómodo y estaré con usted durante todo el procedimiento. Estos 40 segundos de bondad, cuando la gente dice no tengo tiempo para ser bondadoso, con estos 40 segundos de bondad redujo la cantidad de anestesia que requirió el paciente y redujo la cantidad de pasión, de dolor, redujo el número de la cantidad de medicamentos, 60 y tantos por ciento de los pacientes, 64% de los médicos creen que no tienen tiempo para ser compasivos. Esta compasividad, ser compasivos, afecta todo. El regreso a urgencias, el burnout del paciente, el reingreso hospitalario. La compasión beneficia a todos. La compasión marca una gran diferencia. No únicamente para la persona que recibe la compasión, sino para aquel que da la compasión. Cuando sufrimos por la pandemia de COVID, estaba pensando yo en el poder que tienen las relaciones y cómo COVID no nos permitía reunirnos. Por lo tanto, en Navidad, como pueden imaginar, la época con una familia tan grande como la que tengo yo, tenemos a más de 200 miembros de la familia, hice una lista por separado a todas las personas de esa lista que vivían solos en la familia. Y desde que empezó COVID, todos los días hablaba, mandaba una carta, un mensaje de texto, por lo menos a una de estas personas que vivían solas en la lista. Y me dijeron que este contacto durante COVID marcó una diferencia. Esta conexión, la idea de que alguien estaba reconociendo que estaban solos en casa, esto marcó una gran diferencia para ellos. También marcó una diferencia para mí, que practiqué la compasión, por haber sentido la gratitud que ellos me daban. Este texto en un mensaje SMS, una breve carta, un mensaje, una conversación de 40 segundos, beneficia. Esta es mi madre, la madre de los 9 hijos, en su cumpleaños 78. Nosotros salimos para celebrar su cumpleaños Le hicimos una fiesta de cumpleaños a mi madre y una semana después ella padeció de un AVC masivo, entró a la UCI en un ventilador y pasó como una semana con el ventilador y quedó de manifiesto que no se iba a recuperar del AVC. Por lo tanto, este médico con compasión y su enfermera nos pidió que nos reuniéramos con familia, toda la familia. Imagínense, necesitábamos un lugar amplio para traer a toda la familia. Nos reunimos y dijo el doctor, platíqueme sobre su madre. Y yo soy la mayor y la única que trabaja en la atención a la salud y decidí hablar. Tiene 78, es diabética, tuvo reemplazo de cadera. Y entonces dijo el doctor, no, platícame de tu madre. Y mi hermano, el más joven, que siempre era el que daba lata, y dijo, yo le platico. Ella todos los días me decía que era su hijo favorito y todos empezamos a reírnos. Y entonces durante toda esta hora platicamos sobre nuestras anécdotas, sonreímos, lloramos, qué le hacía reír, qué le hacía llorar. Fue un momento que disfrutamos para poder tener estos recuerdos de mi madre en ese salón. Al final de esa hora, con este médico, llegó otro médico de la UCI y estuvo ahí con nosotros y dijo, su madre ha sido intubada y necesitará un tubo para respirar el resto de su vida, no va a recuperar la conciencia. Tenemos, pues tiene que buscar una casa de retiro donde puedan cuidar de ella sin que recupere la conciencia con todos estos tubos. Y luego vio el reloj y dijo, perdón, pero me tengo que ir a trabajar. Y mi hermano más joven dijo, sí, porque mi mamá está por morir, no es parte de su trabajo, doctor. Fue una experiencia ver la diferencia del primer doctor que veía al alma de la paciente contra el doctor que veía el cuerpo del doctor. Entonces, finalmente, en la atención a la salud no nada más podemos ver la parte clínica, tenemos que entender el impacto, tenemos que entender qué está sucediendo con la familia, del paciente. Y esto puede cambiar la forma en la que pensamos, puede cambiar la forma en la que trabajamos. Al día siguiente llevamos a mi madre a la casa, tuvo una semana con nosotros en casa antes de fallecer, pero pudimos cuidarla durante esta semana, al igual que mi hermano. Fue un tiempo para poder celebrar su vida y que su fallecimiento fuera de la mejor manera posible. Recuerdo en el hospital, el director general del hospital, que era amigo mío, salió y me dijo, oye, si hay algo que puedo hacer por tu madre, pues me dices. Y dije, no, infortunadamente no se puede hacer nada por ella. Y dijo, ¿el qué puedo hacer por ti? Y dijo, sí, puedes eliminar los horarios de visita, puedes hacer que me permita estar con mi madre ahora que está falleciendo y no quedarme ahí encerrado en la UCI. Dijo, no tenemos horas de visitas, no te estamos encerrando. Entonces lo llevé a la UCI y le dije, mira, este es cómo se ve la foto de UCI, siempre está cerrada, tiene uno que llamar por teléfono desde afuera y pedir el permiso para poder entrar con su ser querido que está en la UCI. Y yo, siendo enfermera de calidad, yo pude dar un seguimiento a cuántas veces decían sí o no, estamos ocupados, regrese más tarde. El 90% del tiempo decían estamos ocupados. Las enfermeras tenían las ventanas con letreros para que no se viera y un letrero que decía alto y decía, yo siempre camino, dijo el director, por esta puerta y nunca había visto todo eso, me había dado cuenta. Y nunca me había dado cuenta, me había dado cuenta de este letrero que dice alto, nunca. Entonces checaron de tener que verificar con la enfermera para poder entrar a la visita del paciente. Una semana después, así se veía, con puertas abiertas. Esto cambió por completo la experiencia que tenía el paciente y su familia. Pero también esto empezó a cambiar la cultura de este centro. De repente la gente se da cuenta que no tenemos reglas que dicen no eres parte del equipo de cuidados, porque lo somos. Y creo que esto marca una diferencia para todos nosotros y marca una diferencia en el caso de mi madre. 2 años atrás iba yo en un avión a París para dar una plenaria y pues estaba en el vuelo de madrugada. Estuve revisando mi presentación, tomé un número del New England y leí un artículo donde decía en el New England, no nada más, hay que preguntar, ¿qué problema hay? Tenemos que preguntar, ¿Qué importa para usted? La autora Jane Rogers de Massachusetts. Finalmente ahí yo me detuve en el avión y reescribí mi presentación en París. No nada más tenemos que ver qué importa, sino qué importa para la persona. Y esto lo dije al público. Cuando uno regrese a su centro, al primer paciente que usted vea, no nada más pregúntele qué importa, sino qué importa para usted. ¿Qué problema hay? Sino qué importa para usted. Jen Rogers me escribió de Glasgow, la enfermera pediátrica, y recibí el correo en donde describió la experiencia más increíble cuando llegó con Kendra, una paciente de autismo con 11 años de edad que no podía hablar, y después de escuchar mi presentación, vio cómo ella y su padre se comunicaban, y el padre tuvo un evento cardíaco y se había llevado al hospital del otro lado de Glasgow. Kendra estaba sola, pero Jane le dijo, como ella y su esposo y como el padre había tenido esta conversación previa, sabía que era importante y sabía cómo cuidar a Kendra. Y dijo, esto marcó una diferencia por completo. Y entonces empezó a explicar esto en otros centros pediátricos de su país y con enfermería pediátrica. Y de repente todo el mundo en Escocia se dieron cuenta que la forma en la que ellos se preocupaban por los demás, que primero preguntaran, ¿qué importa para ti? ¿Qué te importa? El año pasado Jane Rogers, la enfermera, fue nombrada como la mujer del año en Escocia por la reina de Escocia por cambiar la cultura de la atención a la salud en toda Escocia. Esto se diseminó tan rápidamente de Geraldine Mash, que está en el centro, hasta que yo recibí en portugués una nota de Brasil. En todo el mundo la gente dijo que rápidamente se estaba adoptando esta pregunta. En Noruega, ahí tenemos el tablero de una casa de retiro que visitaba. Cuando pensamos en las casas de retiro en Estados Unidos, normalmente tienen el nombre del paciente, la edad, el estatus de resucitación, nombre del médico y alguna otra información médica. Pero finalmente, una persona joven que estaba en el público en París, que escuchó mi presentación, empezó a cambiar las cosas. Y ahora este tablero tiene la foto de la persona que importa para ese paciente, cómo les gusta que les llamen, por qué nombre, y luego el resto. Entonces, a ver, platícame de esto, de este tablero. Entonces dijo, bueno, tiene 88, a las 5 de la tarde quiere un whisky. Y me sonreí porque, bueno, ya de esta manera lo conocía más. A ver, platícame de esta otra señora. Y decía en mayúscula, nunca me saques de mi recámara si no me han pintado y si no me han maquillado y peinado. Así pues, en todo el mundo la gente empezó a entender la importancia de saber qué importa, qué es importante para el paciente. Esto marcó una gran diferencia en la forma en la que trataban a los pacientes, los veían y también cómo se relacionaban con los pacientes y con la familia y entre el personal mismo. Así pues, esto se ha diseminado, esto se ha extendido en todo el mundo y estamos viendo que hay diferencias increíbles gracias a este esfuerzo. Esta es una historia de Bélgica. La mujer de la izquierda, Annemie, médico una mujer que se dedica a la producción de videos y de películas para la televisión. La señora de la derecha, Vivian, paciente de la UCI. Annemie estaba haciendo una producción de video sobre el sistema de atención a la salud belga. Y entonces durante semanas entraba, salía, entrevistaba a las personas y siguió regresando a ver a Vivian, que estaba intubada y no podía hablar. Pero cuando la extubaron, Annemie le dijo, oye Vivian, platícame, ¿qué fue esta experiencia para ti en el hospital? Y Vivian, y entonces dijo, siéntate aquí, hizo a un lado y dijo, ve el techo, es lo único que he estado viendo durante 3 semanas, el techo. La gente viene, habla encima de mí, me siento que estoy aquí sola. Y dijo, es algo solitario, de nada más estar viendo el techo. Annemie le dijo, ¿qué sería un buen día para ti hoy? ¿Qué sería un buen día para ti hoy? ¿Qué importa para ti? Y Vivian le dijo, lo único que importa es comer un mango. Annemie le trajo un helado de mango y un mango. Y cuando regresó al hospital, se sorprendieron los médicos y la enfermera sobre el impacto que un simple mango tenía en una paciente. Y todos se dijeron, ¿por qué nunca habíamos realmente preguntado esta pregunta antes. ¿Por qué nunca habíamos preguntado qué le importa? ¿Qué es importante para ti? Esto cambió la cultura en Bélgica, en todo el país, y ahora le llaman esto momentos mango. Momentos mango que ahora se está extendiendo por toda Europa. Empezaron a ver que la gente, al igual que Annemie, la gente que trabaja directamente con los pacientes, la gente que ve los retos que se enfrentan, en realidad están creando nuevos modelos para la atención a la salud, con base en lo que importa, con base en la compasión, con base en la bondad. Estos modelos están teniendo un enorme impacto en la experiencia del paciente y del personal. Ahora lo que importa para ti es un movimiento que se encuentra en 50 países en todo el mundo. Tenemos videollamadas donde ustedes pueden participar. Hablamos de el programa, anécdotas, y muchas veces dicen que están esperando ansiosamente esta llamada mensual y que esto les cambia la vida. Si alguien estaba pensando que estaba esperando tener un Lamborghini o algo complicado, hicimos una pequeña matriz que usamos en las unidades de enfermería y en prácticas de médicos en el mundo. Y encontramos que con esta matriz frecuentemente lo que la gente pregunta son preguntas sencillas, y esto lo puede uno hacer por sí mismo. En ocasiones son cosas más complicadas, pero el llenar esta matriz le dio a la gente una idea de que podían hacer la pregunta, ¿qué es importante para ti? Y hemos encontrado que de 60 al 70% del personal están cambiando su práctica como resultado de hacer esta pregunta. El 70-80% del personal está aprendiendo algo nuevo. Y de 80 a 90% del personal reporta que está mejorando su conversación. Lo que empezó con preguntar qué es importante para usted, paciente, es un movimiento en el mundo que está marcando una diferencia. Cuando preguntamos qué es importante para usted, sea paciente o personal, lo cual la oportunidad de la gente, ya ha habido cambios en la forma en la que capacitamos, en la que asignamos al personal, marca una diferencia en el mundo, marca una diferencia para pacientes en todo el mundo, este movimiento. Quisiera dejarles, si me permiten, una herramienta recientemente desarrollada, le llamo yo las 4 T's. A medida que nosotros rediseñamos la atención a la salud con compasión y con un diseño, tenemos que pensar en las 4 T's, en el tiempo, con qué frecuentemente estamos interactuando con la gente. Se trata de una vez al mes, es una vez al día. Podemos diseñarlo mejor con los tiempos. Si entendemos qué tiempo estamos tratando de hacer, con qué frecuencia, y no tiene que ser uno, pero el tiempo realmente es algo que tiene que aumentarse. El touch, el contacto, el tacto. La gente, al tener este tacto, sienten que la persona en visita, puede ser también una visita por video, pero muchos de los pacientes dicen el poder tener tiempo, definir. Todas estas nuevas tecnologías, utilícense, realmente hay apertura al tocarse a través de diferentes técnicas y métodos, no nada más la parte del tacto, no nada más de tener visitas como las que hacíamos antes. Teamwork, el trabajo en equipo, todos tenemos que trabajar como equipo, porque el trabajo en equipo genera confianza. A medida que nosotros pensamos en la siguiente parte de su viaje, les dejo lo siguiente: necesitamos ver a la persona como un todo, no nada más el diagnóstico, no nada más un órgano. Tenemos que mapear los activos o las propiedades que tiene la comunidad, no nada más los profesionales. Toda la gente de la comunidad también puede participar, están fuera de la profesión, la comunidad se puede reunir. 3, rediseñar la atención con las 4 T's que les he mencionado, y también preguntar a la comunidad y al paciente qué importa para ellos. Ahí tenemos esta información. Podemos tener 1000 láminas, pero lo importante, tenemos nuestra página web, así como también el contacto, en donde creo que les ayudará, wmty.world, o la página que ahí aparece enlistada. Ahora pasamos a la sesión de preguntas y respuestas. Gracias por su amable atención.
¿Preguntas aquí en el auditorio? No sé si me puede escuchar Maureen Bisoñano. Maureen, can you hear me?
Any questions? I can't hear any questions. Cesar, do you have a question? I think you're on mute.
Can you hear me? Yes, there is one question. I hope you can hear this one. Adelante, por favor.
Hello. What happens when the patient wants to die?
What happens when a patient wants to die? Here in the United States, it depends on what state you're in. Many of the states here are allowing people to make those clinical decisions with their doctor. So if somebody has a terminal illness, like my brother, it allows them to go home and to have family and supports around them to take care of them. In some states, you can even take a medication to help you. In other states, it's not legal, and there's no way for you to help yourself to die if you are ready. Is that helpful?
Yes, Maureen. But I'm not sure, no estoy seguro de que ella pueda escuchar lo que yo digo en este micrófono. Can you hear me, Maureen?
Yes, I can.
Okay,
Can.
good. Okay,
Can.
good. Well, you should know now, and maybe it's late, but that you were speaking from the same place that you were here about 10 years ago in the auditorium of the National Academy of Medicine, where you helped us at the time to speak to an audience that wanted to improve quality of care in this country, responding to the call of the then Minister of Health, Dr. Mercedes Juan. So you are again in the same place. Unfortunately, not presently, but certainly we've been very, very grateful for you to be with us at a distance. ¿Alguna otra pregunta para Maureen? Well, Maureen, I can't see you, and I'm not sure that you're seeing me, but anyway, thank you very, very much again. We'll have a chance to talk soon and to share with you what the next steps are in this country, at least from the causa perspective, to keep moving ahead. Now, along with the institutions, the Mexican Institute for Social Security, the Secretary of Health, the other rather new organization, IMSS Bienestar, to keep pushing towards a better human approach in our services, Care Human. Thank you very much, Maureen, and look forward to see you soon. Bueno, si no hay ninguna otra pregunta por ahora, muchas gracias a Maureen, muchas gracias a ustedes. Los esperamos el día de mañana a las 9 de la mañana. Volvemos a iniciar con la segunda parte del Congreso. Hasta mañana.